I hope you had a good celebration, no? Happy New Year! Okay pala. Happy New Year sa inyong lahat. Okay. Sorry ha. Yeah. Nag-aalaga ako ng baby kasi. Okay. So, ayan. Ayan. So, Happy New Year sa inyo lahat. I hope nakapag-celebrate ba ang lahat or ano ba? Napuyat ba sa pag-aaral? Ano ba? I hope na okay ang inyong celebration ng New Year. And sabi ko nga sa mga babies ko, di ba? I am claiming that this year would be the year that you will get your license. Di ba? Yun ang importante. Ayan. So makukuha nyo ang license nyo this March. Okay? So yan, this will be the best year that you will have. So, ano ba? Ready na ba kayo to have our Quizmaster Refresher Lecture and Introduction to your next subject? I hope you guys are all ready. Okay? Sige, sorry. Ayan. Medyo, ano pa tayo? Nasa 2022 pa ata ang brain cells ko. I'm actually not feeling well today because my allergic rhinitis is acting up. So pagpasensyahan nyo na ako mga bees. Oo. Ano tayo ngayon? Medyo slow mo. Okay, so before we start, I would like to invite you to join me in prayer. Okay? In the name of the Father, and of the Son, and of the Holy Spirit, amen. Lord, true source of light and wisdom, give me a keen sense of understanding, a retentive memory, and a capacity to grasp things correctly. Grant me the grace to be accurate in my expositions and the skill to express myself with thoroughness and clarity. Be with me at the start of my work, guide its progress, and bring it to completion. Grant this through Christ our Lord. Amen. Father, Son, Holy Spirit. Amen. Ayan, mga bees. Okay pa ba? Okay. Ayan. So, let's see. Sino ba ang nasa room natin? Okay, wala si Doc Broly today. But I would proceed, okay, to our next part of the program. So, ayan. Nakakain na ka ba kayo? Okay. So, ready na. I-introduce ko na yung ating speaker for. Nakapag-aral ba kayo ng Pedia? Okay, Pedia is actually, ano ba, sabi ko nga sa mga BBs ko, it is one of the fair subjects. However, ang tinatanong kasi nila is must know subjects, di ba? But kailangan nyo pa rin siyang aralin, mga Bs. Kasi pag hindi nyo alam yung mga must knows, hindi nyo inaral, akala nyo it's so easy, di ba? Medyo ano kayo doon, dehado kayo doon. Kailangan, you should still study this subject and know, kumbaga, i-prioritize nyo yung mga kailangan nyong malaman na usually naman ay ginagawa ay tawag dyan, in-emphasize naman ng mga lecturers ninyo and sa inyong mga quizmaster sessions. Okay? Okay, so for tonight's refresher lecture, we have Dr. Adrian Salvador M. De Vera, a graduate of UP-PGH, and took his residency at the Philippine Children's Medical Center. And he was actually awarded the Joel Elise's Most Outstanding Resident during his residency. And he is the co-author of Pedia Platinum and COO or Chief Operating Officer of the De Vera Medical Center. Apply na kayo after nyo pumasa sa kanya, okay? And he is also a newborn photographer. So yung mga gusto magpa picture dyan ng mga newborns nila, no? At Nuvoni Photography, and YouTuber sa mga mahilig sa mechanical keyboards. His YouTube page is YouTube channel is Athoki Doki, and he has been a pediatrics lecturer for a decade already here in Top Notch. So ayan. So good evening. It is my honor to introduce to you my husband, and we share the same surname and two kids. Yan, si Dr. Ian De Vera. Dito na ba si Doc Ian? Doc Ian, yes, are you here?
Hello. Yes.
Ayan.
Ayusin ko na sandali.
Sige, Doc. Wait lang ha. Yan.
Pwede na ba ako mag-share ng screen?
Yes, Doc. So yan, Bees, kung may mga questions kayo kay Doc Ian, message nyo yung mga mother goose ninyo, okay? And yung mga BBs ko, you can send your questions here in the chat box, or you can also send me a Viber message, okay? Doc Ian, are you ready?
Okay na ba? Kita mo yung PowerPoint ko?
Yes, Doc. Kita po.
No.
Okay, Doc. The virtual floor is yours.
Thank you. Hello, good evening everyone. Malinaw ba? Malinaw?
Yes, Doc. Clear po.
Okay, sige. So let's start our summary lecture for pediatrics. So I hope marami kayong natutunan during your pedia review. If I'm not mistaken, this week was mostly or all about pedia, di ba? So this is our summary lecture. Basically, very important bullet points, the most important topics that I think should be covered. Okay, so hopefully we can finish this in an hour or so. So again, dapat guys, most of the things that I will be discussing in this lecture, dapat familiar na kayo. Dapat konting-konti na lang yung sobrang hindi pa familiar. All right? So let's start. So neonatology, okay? So guys, please remember your EINC, okay? Remember the 4 steps and remember why we're doing this, okay? So this is the arrangement. So immediate drying, skin-to-skin contact, cord clamping, and non-separation of the mother and the baby. So this is the order kapag yung baby nyo is born via NSD. Kapag cesarean section yan, syempre, magpapalit yan, mauuna yung cord clamping bago yung skin-to-skin. So magpapalit to kapag cesarean section. So know the purpose, okay, why we're doing this. So immediate drying for prevention of hypothermia and to stimulate the baby, very important. And also, ito tinanong to sa isang exam before, ano yung thematic order ng pag-dry ng baby. So they went into that detail maybe 2 or 3 years ago yata yan, tinanong yan. So ito yung order niyan, 5 seconds each, face, head, trunk, back, arms, and then legs. Okay? Duration is skin-to-skin contact. Nabanggit ko na sa inyo, that's 30 minutes to 60 minutes. Latest guidelines will tell you until the first full breastfeed. And ito yung mga purpose niya. Okay? Cord clamping, 1 to 3 minutes or until pulsation stops. Lagi nakakalimutan ng mga students to. Okay? This is or. So, or until pulsation stops. So, whichever comes first. Prevention of anemia for both full term and preterm. For preterms, it has an additional benefit of preventing your intraventricular hemorrhage. Okay? And of course, very important, increases breastfeeding success and for term regulation. That's why you do not separate the mother and the baby. Ideally, dapat magkasama yan, dapat naru-room in yan. All right? Wait lang guys, 5 minutes lang. I have to take a call. Sorry.
Ayan, Doc. Sorry. Busy si Doc Ian kasi baka meron siyang pasyente. Okay, mga Bees, ano ba ang ating gagawin tonight? So after ng pediatrics refresher lecture ninyo, you will have your quiz master. So I encourage all my BBs here in the Zoom room to participate kasi it's better, no? Paulit-ulit ko tong sinasabi sa inyo, better na magkamali kayo ngayon. Don't be afraid to make mistakes now and to learn from the questions kasi matututunan niyo yung mga topics na most commonly tinatanong sa board exam, and then you will get to practice yung inyong test taking skills. So yan ang technique ng top notch, ginagawa namin yan. So if you can see the pattern, we do pre-test muna, tapos you and read the handouts and listen to the video lecture. After, you will have your post-test, no? So test taking is very, very important, no? And that's what we want you to practice from now until March para masanay na yung brain nyo na hindi lang basta passive reading, but more on, you analyze and think ano ba yung mga pwedeng itanong, no? Pag binabasa nyo yung mga handouts ninyo. And then, ano pa ba? So I think Doc Roy will here, and then another recent passer, board passer. So para magkaroon kayo ng idea how we go about how it attack yung next week's subject, which is microbiology. So ayan. So usually, ano pa ba? Maraming mga crossover questions. Ang pedia, when I took the board exam, marami siyang very basic questions, but at the same time, like APGAR, no, I think Doc Ian is always emphasizing that kasi tinatanong talaga siya. And ma-remember niyo yung mga sinasabi ng mga lecturers niyo, ng mga refresher lecturers, and of course yung main lecture niyo, ma-remember niyo yan if you keep on repeating or tinatandaan niyo yung mga sinasabi nila. Ano pa during my time, I took the board exam same time last year, no, March. So pareho tayo. This time last year, nag-aaral din ako talaga. New year, and it was really, I could understand, no, what you're going through at this point, and parang nagpapanik-panik na ako ng mga January. Pero mabilis lang yon. Kailangan makarecover mga B, di ba? Kailangan, after yung panic ng mga 30 minutes, tapos kailangan yung mag-aral ulit kasi sayang yung oras. Totoo yun. Kailangan yung prioritize, and I guess focus, di ba? Focus on the goal. That is to pass the board exam. Okay?
Hello. Sorry. Okay. Sige. Yan. Okay na ba? Narinig niyo ako? Narinig. Clear? Clear ba? Okay, sige. So other important EINC facts, routine suctioning should be done. So no. So again, you only do suctioning if the baby is in distress tapos maraming secretion. So even if meconium stain, di kailangan sinasuction yan. Okay? Delivery room temperature, laging tinatanong sa exam yan. It's 25 to 28 degrees Celsius. That's your target temperature. Dapat ganyan ka-warm yung room temp nyo. Normal newborn temperature, 36.5 to 37.5. Low birth weight is less than 2,500 grams. Again, do not confuse this with SGA. Iba yung low birth weight, iba SGA. Late preterm is 34 to 37 weeks. Very important kasi physically, pag tinignan nyo sila sa unang tingin, para na silang full term. But when you do your Ballard scoring, kulang pa pala sila ng 37 weeks. Very important because yung mga complications expected of prematurity, nasa sa kanila rin. So, pwede silang mag-RDS, jaundice, hypoglycemia, ano ba? Duodenal atresia. So, yan. So, these are still considered preterm babies, even though physically they look mature. So, ayan. Small for gestational age is less than 10th percentile. Large is more than 90, very important. And for large babies, ito yung mga complications natin. Birth injuries, dahil malaki sila. Polycythemia. Because of polycythemia, they're prone to developing jaundice. And also hypoglycemia, lalo na pag may maternal diabetes. Alright? Priority in newborn resuscitation. Binanggit ko na yan, in-emphasize ko na yan, it's always your airway. Okay? Airway, breathing, then circulation. And then remember your ventilatory corrective steps when doing your resuscitation. The mnemonics is Mr. SOPA. Okay? When do you do chest compression? Anytime if your heart rate falls below 60 beats per minute. Okay? So, magsi-CPR ka pag during your resuscitation, mabagsak siya ng 60 beats per minute. Doc, paano paglabas ng baby? Kalalabas pa lang ng baby tapos wala siyang heart rate. Anong priority ko? Again, ABC pa rin. So, stimulate pa rin, ambubag pa rin. Tapos, pag hindi nagpipick up, then you do your CPR. Okay? Upon suctioning the baby grimace, what is the APGAR score for reflex irritability? Remember that grimace is 1. So, I think minention ko na to pero wag kakalimutan. Pag may nag-APGAR score na question sa exam, dapat makukuha natin yan. Dapat sure na makuha natin yan. Sayang yung 1 point. Okay? So, madalas dito nagkakamali sa grimace. Ang grimace is not 0. The score for grimace is 1. Hindi rin siya 2. Ang 2 for reflex irritability, dapat iiyak si baby. Okay, dapat active yung flexion, dapat may irritate siya dahil nag-stimulate ka. Right? Okay. So, ito, binanggit ko rin to in detail in my main lecture. So, again, remember these diseases and how you differentiate them from each other. Galactosemia manifests with problems in the kidney, liver, and brain. PKU and MSUD, mostly brain, central nervous system. How do you differentiate the two? PKU has a musty odor, gradual. Maple syrup urine disease, mabango yan, tapos mas mabilis yung onset. G6PD is acute or chronic hemolytic anemia pag nakakain sila or kapag may intake sila ng oxidative stress na nagtitrigger ng mga oxidative stress such as your fava beans, your red wine, your mongo, okay? Soy and tofu, okay? But take note, hindi lang puro pagkain, even stress, infection, injury, trauma, they can also trigger hemolysis. So please take note of that. CAH, again, the most common is your 21-hydroxylase deficiency, okay? Usually, they are normal at birth. They can have ambiguous genitalia, okay? For 21-hydroxylase, you have sexual and somatic precocity. And here are your derangements in your blood, in your electrolytes, hyponat, hyper-K, and hypogly. Again, go back to the beautiful flow chart that tells you why these are the manifestation for your 21-hydroxylase deficiency. Nandun yan. I discussed that in detail dun sa ating lecture. Congenital hypothyroidism presents with global delay, usually with macroglossia and GDD, global developmental delay. Okay, pakidagdag again dyan, jaundice, prolonged jaundice, and delayed tooth eruption. Okay. This one is also very important. Laging tinatanong sa exam, ano yung difference nung tatlo? Caput versus cephal versus subgaleal. Caput is superficial. At dahil superficial siya, it crosses the suture line and mayroon siyang discoloration. Mabilis mawala si caput, 2 to 3 days. Cephal and subgaleal mas malalim. Cephal is subperiosteal bleed, okay, dun sa ilalim ng buto. That's why it does not cross your suture lines. Hindi siya tumatawid kasi nasa may boundary siya, yung buto mismo, yung buto ng scalp nyo. And dahil malalim siya, there's no discoloration. And usually, initially, it progresses. Ang caput, kung ano yung size niya sa start, hindi niya lumalaki. Ang cephal pwedeng lumaki. Pero mawawala rin naman kusa yan in 2 to 3 weeks. Most of the time, minomonitor lang yan. Subgaleal is from the rupture of your emissary veins. The location is below your epicranial aponeurosis. Okay? Toxic may extend to the nape and the periorbital area. Okay? It progresses, but it can resolve usually in 2 to 3 weeks as well. So, hindi lahat ng subgaleal naman namamatay. So, pag may mga iba may subgaleal, tapos maganda naman yung bleeding parameter, hindi sobrang laki ng subgaleal hemorrhage niya, hindi siya nag-extend, okay lang. Pwede pa rin mabuhay yung baby dyan. Okay? Pero among the 3, pinaka-toxic si subgaleal, pinaka-benign si caput. Alright. Surgical conditions in neonates. Okay? Early onset difficulty of breathing, frothing of the mouth, tapos nag-exacerbate after feeding, unable to pass your NGT. The most common type is type C. This is your EA, esophageal atresia, with or without your fistula. Okay? Scaphoid abdomen, difficulty of breathing, early onset. Bowel sounds on the chest wall. So that's a giveaway. This is your congenital diaphragmatic hernia. Most common type is your Bochdalek hernia. Okay? May nakalabas na bowel content, may sac, nakabalot siya. It's midline compared to the other one which is lateral, okay, to the umbilicus. Ito, midline to. Associated with other congenital anomalies, this is your omphalocele. Okay? Yung isa, gastroschisis. Gastroschisis yung walang balot, located to the right of your umbilicus. Okay? Preterm stormy clinical course, nagbigay ng feeding. Tapos after nag-feed, pumangit. Tapos on X-ray, pneumatosis intestinalis. Again, this is not pathognomonic for this disease, but it is highly suggestive. And then you can also have pneumoperitoneum. Hindi lahat meron, pero pag nagkaroon ka ng perforation, magkakaroon ka ng pneumoperitoneum. This is your necrotizing enterocolitis. Alright? Alright. Early onset venous vomiting. Premature. Hindi malaki yung tiyan. Mayroon siyang obstruction, pero hindi malaki yung tiyan. Tapos meron kang double bubble sign. This is your okay, hindi lumalaki yung tiyan kasi wala kang connection between your duodenum and your stomach. This is your duodenal atresia. Okay? Ito, very important. Tinatanong to sa exam, pero this is also very useful in your practice when you go to general practice or even through residency. Urine output in neonates should be present within 24 hours. Passage of meconium ideally within 24 hours as well, pero pwede tayong mag-extend up to 48 hours. So ito yung upper limit niya, 48. So madaling tandaan, 24 tapos 48. 1 day, 2 days. Okay? Respiratory conditions in the newborn. Surfactant is present by what AOG? At 20 weeks, it's already present, okay? Pero it can be detected in the amniotic fluid at 28 to 32. It only reaches mature levels at 35, meaning before 35 weeks, probably hindi pa mature yung surfactant nyo. Probably malaki yung chance na mag-develop ng respiratory distress syndrome. Okay? Your surfactant functions to reduce the surface tension in the airways. Alright? Doc, paano pag more than 35 weeks? Hindi na ba siya pwedeng mag-RDS? Pwede pa rin. Pwede pa rin. Dahil marami namang causes ng RDS. So, pwedeng mature nga yung surfactant mo pero nasira siya because of infection, because of meconium aspiration. So, hindi yan exclusive. Hindi siya preterm lang pwedeng magkaroon ng RDS. Cessation of breathing, loner. Hindi yan loner. Longer yan. Kawawa naman siya. Loner siya. Longer than 20 seconds or any duration if accompanied by cardiopulmonary compromise. So, less than 20 seconds pero nag-cyanosis. So, that is what you call severe apnea. Is apnea more common in preterm infants? Yes or no? Yes. So again, maraming complications, maraming physiologic problems na ina-expect natin kapag preterm ang isang bata. Alright. RDS, more common in preterm infants. Okay. Chest X-ray, you see ground glass opacities. Because of the lack of surfactant, you have underinflation. Because of the lack of surfactant, mataas yung surface tension, nagko-collapse yung airway, you will have atelectasis. Okay, very important. Presentation, early onset, usually preterm, does not respond well to oxygen dahil kailangan niya ng pressure to open up your airways. It may present with grunting and usually it progresses during the first few days. Management is surfactant, pressure, and of course, prevention by giving antenatal steroids if you're expecting a premature delivery. Of course, the best way to prevent this is to reach by full term before delivering the baby. RDS, TTN, on the other hand, is more common in full-term infants delivered by CS. Usually normal ang X-ray. If not normal, they can also have prominent markings, okay? And usually hyper-aerated lungs. Early onset din, but compared to RDS, they respond well to oxygen and quicker ang recovery. In usually 2 to 3 days time, usually okay na yung mga batang yan. Management is supportive. All right. Let's now go to jaundice. Very favorite topics to ng mga examiner, okay? Bilirubin used in determining management based on the Botany chart, it's your total bilirubin. When we're talking about neonatal jaundice and phototherapy, Botany chart, remember, it's the total that matters, okay? Pero pag tinanong kayo, ano ba yung nagkukos ng jaundice sa bata? Ano ba yung bilirubin na mas common na nagkukos ng jaundice? Is it the direct or the indirect? It's usually the indirect, okay? For neonates, we're talking about neonates. Mas mataas yung indirect, sila yung nagkukos ng neonatal jaundice, okay? And yung indirect, sila din yung problem natin kasi sila yung pwedeng umabot sa brain to cause the damage which you call as kernicterus, okay? Most common cause of jaundice in newborn is still physiologic, okay? Ito yung sinabi ko kanina. It's your indirect, your unconjugated bilirubin. It's lipid soluble. It crosses the blood-brain barrier. Okay? Sinulat ko dito to kasi laging nalilito sa exam na pagpapalit-palit yung ano ba yung direct, conjugated, saka B2. So, ito, indirect, unconjugated, B1, all in the same, yan yung tawag dyan. Alright? Treatment for jaundice in neonates, it is your phototherapy. There are various mechanisms of action, but the most commonly asked one is photoisomerization, meaning it converts your bilirubin into isomers na mas madaling i-excrete ng katawan at hindi toxic sa katawan. Okay? Duration of your physiologic jaundice is 14 days. Beyond 14 days, hindi na yan physiologic except, okay, ano yung exception? Except for breast milk jaundice, because breast milk jaundice is still considered physiologic pero pwede siyang mag more than 14 days, up to 3 months. Okay? So physiologic or pathologic, within the first 24 hours of life, always pathologic yan. More than 12, that's pathologic. Okay? Direct is more than 2. Sabi ni Nelson's, yes, that's pathologic. Okay? Breastfeeding or breast milk, technically speaking, that is physiologic. Mother's O, baby's A. Coombs test positive, meaning you have autoimmune hemolysis, then that is pathologic. Jaundice on the second day of life, the baby is well, bilirubin is 4, mother is O, baby is A. This can still be considered physiologic. What am I pointing out here? Hindi lahat ng may setup, hindi lahat ng O ang mother, tapos A or B or AB yung baby, hindi lahat yan mag-AABO. Pwedeng hindi yan mag-ABO. Malinaw? So, hindi siya automatic na pag O si mother, tapos si baby ay A, B, or AB, hindi automatic na pathologic yan. Depende sa case pa rin. So, basahin niyo pa rin yung kabuuan ng case. Alright? Breastfeeding jaundice is early onset. Inadequate feeding is the most common cause. Okay? Lalo na pag nagbibigay ng tubig si mommy kasi walang calories ang tubig. Maximum is 2 weeks. Management is to increase feeding. Okay? On the other hand, breast milk jaundice is later in onset, 7 days of life. Unknown pathophysiology. Merong theory that it can be caused by glucuronidase. Okay? 3 weeks to 3 months. Okay? Siya lang yung pwedeng mahaba yung duration. And the management is May. So not necessary na i-stop lahat. Pero pag mataas yung bilirubin niya or talagang jaundice siya, you may stop the feeding for 2 days. You may give formula and then resume your feeding. All right? Okay. So let's move on to our next topic. So we go to pediatric nutrition. Okay, breastfeeding and lactation. Watery, high lactose and protein, this is your foremilk. Okay, creamy and high in fat, that is your hind milk. Okay, so please remember that. Protein that triggers cow's milk allergy, that's your casein. Which is predominant, casein or whey? Of course, it's your whey. The ratio is 3:2. So laging tinatanong yung ratio na yan. Galactosemia, is it absolutely contraindicated? Yes. Okay, what about PKU and MSUD? Hindi siya absolute, pero relatively contraindicated siya. Okay, TB and breastfeeding, okay, avoid if possible, pero after 2 weeks of appropriate treatment, you may resume your breastfeeding. HIV and breastfeeding, avoid. Okay, it's one of the contraindications, but if it cannot be avoided, make sure it is exclusive and less duration possible. COVID, baka magtanong sila, paano ang COVID? Paano pag COVID positive si mother? WHO, CDC, PPS will tell you that even if the mother is COVID positive, if the mother is well and she can breastfeed, then it's better to have the mother breastfeed. Okay? Just make sure na nakamask si mommy, naguhugas ng kamay, and other precautions are being practiced. Pero COVID is not an indication to stop breastfeeding. Actually, baliktad. Studies have shown na pag nagbe-breastfeed yung mother na may COVID, there's a better chance that the baby will not get infected or the baby will do well compared pag nag-formula. Alright? Alright. Let's now go to your micronutrients. Difficult to treat eczema, diarrhea, low alkaline phosphatase, nasabi na natin dati yan. This is your acrodermatitis enterohepatica caused by your zinc deficiency. Rachitic rosary, Harrison's groove, windswept deformity. Pag puro bones yung manifestation, think of vitamin D. Okay, this is your rickets. Pag mas matanda, osteomalacia yung tawag dyan. Ito naman, scorbutic rosary. Okay, irritability, hemorrhages, chelosis, and glossitis, that is your scurvy. Prevention of hemorrhagic disease of newborn or your VKDB, vitamin K deficiency bleeding, you give your vitamin K prophylaxis at birth. Minerals in breast milk that are dependent in the maternal status. So, kailangan hindi maging deficient si mother dito. Otherwise, pwedeng ma-pass on kay baby dahil madi-deficient yung breast milk niya. Vitamin D and iodine. Dalawa lang yan. Minerals in breast milk where fetal stores are sufficient for the first few months of life, your zinc and iron. Nagkakaroon ka na ng stores during the fetal period, and those are adequate to cover for the first 6 months of need. That is why you don't need to give these micronutrients before 6 months of age. Again, we are talking about healthy full-term babies. Pag preterm or small babies, probably you need to give your supplementation. Okay. Main pathophysiology of malnutrition, bakit ba nagkakaroon ng kwashiorkor? Bakit ba nagkakaroon ng marasmus? It's because of your reductive adaptation. Measurement used to determine acute malnutrition. You can either use your weight for length, okay, or your upper arm circumference. So values are provided there. Again, less than -2, wasting. Less than -3 is severe wasting. Okay. MUAC of less than 11.5 is severe wasting. Okay. Remember, your MUAC, you can only use that for 6 months to 59 months. Okay. Protein energy, kulang sa protein, moon fasces, fatty liver, severe anemia, neurologic deficits, kwashiorkor or marasmus. This is kwashiorkor. Old man, walang edema. Tapos ang problema, wala siyang subcutaneous fat. Ito yung mga payat na payat yung mukha sa kayong katawan. This is marasmus. The hallmark of refeeding syndrome, again, maraming electrolytes yung nade-derange. Potassium, phosphate, okay? But the hallmark is severe hypophosphatemia. Okay? And the pathophysiology of refeeding syndrome, sino yung salarin? Ano yung sabi ko sa inyo? Who causes this? It's your insulin surge. Diba? Matagal silang depleted, hindi kumakain, and then bigla mong pinakain na maraming pagkain, you get your insulin surge. That's your refeeding syndrome. Okay? Immunization and IMSI. Okay? All right. Can this be given simultaneously? So again, sabi ko sa inyo, pag ang tanong simultaneous on the same visit, okay, the answer is yes, wag na kayo mag-isip, di ba? Hep B and varicella, yes. Varicella and measles, yes. Pneumonia and oral polio, yes. Okay? Yes. Okay? Only exception is yellow fever and cholera. There are other brand-specific exceptions, but probably it will not be asked in the board exam, such as your Tdap and your meningococcemia, your meningococcal vaccine. Pero for the board exam, probably ang kailangan nyo lang tandaan is yellow fever and cholera. Okay? Interval between doses, if not given simultaneously. Dito lang tayo mag-iisip kasi kapag parehas na live, kailangan mo mag-antay ng 28 days. Okay? So Hep B and pneumonia, hindi naman yan parehas na live, walang interval. Parehas na live? Yes. Pag oral, kahit live pa yan, walang kailangang interval. Okay? So dito, wala rin. Hib na booster, ideally 6 months from the 3rd dose. So booster doses, medyo may kailangan kayong tandaan dyan kasi hindi yan straightforward na 4 weeks lang yung interval. So after completion of your primary series, usually 6 months yung booster. So this goes for Hib, also goes through for pneumonia. Varicella booster is 3 months from the 3rd dose, but ideally, sabi nga dyan, may asterisk dyan, these are the optimum schedule, but theoretically, as long as the vaccines are given 4 weeks apart, acceptable na yan. Okay. Let's go now to AGE, acute gastroenteritis. Most common etiology in children, less than 2, it's rotavirus. Overall, pinaka-common viral pa rin. Even beyond 2 years old, still virus. Okay? Pag may dugo, dysentery, think of Shigella. Okay? The patient is irritable, sunken eyeballs, drinks eagerly. What is your classification? Some signs of dehydration. Okay? Guys, wait lang ha. 5 minutes ulit. I have to take a call.
Okay, while Doc Ian is taking a call again. Oh, very, very busy ang inyong Doc Ian. Buti nga nahatak natin siyang mag-lecture, di ba? Nag-YouTube na lang yan. Charot. De biro lang. Yeah, yes, patience. So, anyway, wala pang nag-send ng questions sa akin. But to those in the portal, again, if you have any questions, please don't hesitate to message your mother keys, no? And then they will forward your questions to us. Okay? Ano pa ba? May mga announcements ba tayo? Yung mga mentors, no, ay mga nag-mentees, no, na nag-apply for the mentoring program. Please let your mother know if hindi pa kayo na-contact ng mga mentors nyo within the week. Okay? Para ma-follow up natin. Okay, kasi may mga day jobs din yung mga mentors ninyo, and of course, but they have to get in touch with you within the week, no? Para matulungan nila kayo ng mabuti. So to those who want to avail to participate in the mentorship program, you can get in touch with your Mother Goose to give you instructions. Pero nasa portal yung mentoring profile sheet and the brochure of the mentors nandoon din para makapili kayo. Choose 3, no? Para may options kami, kayo na namin kayo i-assign. Ano pa ba? Yon. Okay na ba, Doc Ian?
Yeah, okay na, okay na.
Okay.
All right. Sige. Okay. So this is some signs of dehydration because remember, kailangan mo maka 2 out of 3 of the criteria from IMSI. Okay. And the management for some sign is your treatment plan B, which is ORS 75 ml per kilogram to be given within 4 hours. Okay. Laging tinatanong, your reformulated, your revised, reformulated, newer generation oral rehydrating solution, what is the composition? It's 75 millimole per liter sodium and glucose, okay? And the ratio is 1:1. So very important yan. Compared to the older formula, hindi sila 1:1. Ngayon, 75, 75, 1:1 ratio. Also remember yung osmolarity. It's reduced osmolarity ORS. If I'm not mistaken, 245, 285, or 245. Please do check that in your handout. Balikan nyo kung ilan yung osmolarity ng bagong oresol natin. Okay? Micronutrient supplementation for AGE, the only proven micronutrient that shortens the duration and improves the outcome is your zinc. All right? So, Doc, paano yung probiotics? Ursiflora, Flotera, Biobita, yung mga iba't iba pang lactobacillus na binibigay. There are some studies, pero hindi pa siya ganun ka-solid yung evidence. It's not yet part of the guidelines. Okay? You can give, pero kumbaga, hindi pa siya, what do you call this? Hindi pa siya routine na binibigay. Hindi pa ganun kalakas yung studies. Okay? Let's now go to growth and development. Okay. Very important figures. You have to memorize this. Laging tinatanong to sa exam. Nagdo-double ang birth weight at 4 to 5 months. So, pag pinanganak ka ng 3, nagiging 6. Tapos, magti-triple siya by 12 months. So, 369 kilos. Okay? Social smile is 2 to 3 months. Rolling over is 4 to 5 months. Bubbling. Okay? Bakit nawala siya? Bubbling is 6 months. Object permanence is 9 months. Maraming nangyayari sa 9 to 10 months. You have to memorize that. 9 to 10 months ay first few words, object permanence, crawling. Okay, so daming milestones dyan. And walking without support happens at around 12 months. Okay? All right. Ito, dinescribe ko to sa video. Meron pa akong ginamit na manikin. So, sudden movement. Okay, followed by so pag nagulat si baby, elicited by sudden movement, loud noise. In your physical examination, ideally ang gagawin mo is ibabagsak mo yung head ni baby, drop it in the examiner's fingers with support. Be careful, dapat may support pag ginawa niyan. And then ito yung mangyayari, iiyak siya, magkakaroon ng extension and then flexion. Then that is your Moro reflex. Okay? And then this too, deficits in socialization, repetitive behavior versus ito, inattention, disorganization, hyperactivity, impulsivity. Again, for the board exam, you have to know the difference between ASD and ADHD. Okay? Si ASD yung mapag-isa, may sariling mundo, repetitive behavior, ayaw niyang nagugulo yung kanyang routine. Si ADHD yung may bulati sa puwet, kiti-kiti, impulsive, sagot ng sagot kahit hindi tinatanong, so forth and so on. Alright? Very different these two. So, dapat alam nyo siyang i-differentiate during your exam. Alright. Let's go to gastroenterology. Okay, profuse rice-watery diarrhea. Ayaw tumigil, tuloy-tuloy. Okay, rice-watery, kulay puti, parang hugas bigas. That is your cholera. Okay? These patients usually go into shock. Okay? Wait lang, nagahang yata ako. Nagahang ba? Okay ba ako? Doc DK, malinaw ba? Okay naman.
Okay po, Doc, malinaw.
Okay lang, Doc Louie. Okay, sige. Alright. So, prolonged fever, abdominal pain, diarrhea, meningismus, and rose spots. So again, one of the great mimickers, pag more than 7 days yung fever, tapos non-specific signs and symptoms, this is one, of course, dapat ito yung isa sa mga top differentials nyo. Think of typhoid, think of salmonella. Okay, rose spots, you only see that in less than 20%, 25-20% of the patients. So, Hindi siya ganun ka-common, pero sa exam, madalas tinatanong din nila yan. Mahilig nilang tanongin yung rose spots na yan. Drug of choice for salmonella na uncomplicated and fully sensitive, it's actually your chloramphenicol. Pero empirically, sabi ko sa inyo, we give ceftriaxone. Okay? Quinolone resistant severe ceftriaxone or cefotaxime. Okay? Dysentery, painful defecation, automatic na yan. Pag narinig niyo yan, may dugo yung tae, masakit pag tumatae, mataas yung pus, think of Shigella. Okay? Culture media, because the definitive diagnosis, the gold standard for diagnosing Shigella should be culture. It's your McConkey, psilocybin, deoxychocolate, or your SS agar. The drug of choice for Shigella is ciprofloxacin. So please remember that. So ideally, again, if the patient has bloody diarrhea, you should be giving ciprofloxacin and not metronidazole. Okay? So metronidazole is for amoebiasis. So pwede pa rin ang amoebiasis sa mga bata, pero less than 30% of the time, diagnosis dapat in your stool, dapat meron kang entamoeba, histolytica, trophozoites with ingested RBCs. Alright. Intestinal obstruction. So again, sinabi ko sa inyo yan, guys. Pag may batang nagsusuka, always rule out obstruction first. And what are the important questions? Again, onset, tapos bilus ba yung vomiting, lumalaki ba yung tiyan, tapos dumudumi ba siya? So pag lumalaki yung tiyan, bilus vomiting, tapos hindi siya dumudumi, wala siyang flatus, then probably there's obstruction. Currant jelly is a giveaway, pero be careful, hindi lahat ng currant jelly ay intussusception. So basically, para lang siyang bloody mucoid stool. Pero when you pair currant jelly with yung paroxysmal pain, on and off pain, tapos sausage-shaped mass, and the portion of your intestine being telescoped inside the same intestine, so pumapasok siyang ganon, then think of intussusception. Look for your donut sign or on your ultrasound, because for intussusception, 98% to 100% sensitive ang ultrasound. Okay? Itong batang to, binigyan ng erythromycin during the neonatal period. It presents with postprandial vomiting, non-bilus, okay? And you have a palpable mass on the epigastric area. The mass is almond-shaped. Okay, this is your pyloric stenosis. So very common in those patients given erythromycin during the first 3 months of life. Kaya hindi natin usually ginagamit yan. So infantile hypertrophic pyloric stenosis, IHPS. Okay, remember again, pyloric stenosis, olive-shaped mass, tapos non-bilus because your obstruction is before the ampulla of Vater. Okay, pag after the ampulla of Vater, magiging bilus siya. On imaging, you look for shoulder sign and double track sign. Absence of ganglion cells presents with constipation. This is a giveaway. Hirschsprung's disease. Look for your transition zone. On biopsy, look for a ganglionosis. Painless bleeding, ectopic tissue. This is your Meckel's diverticulum. Please review and remember Meckel's rule of 2. Okay, very important. All right, so this is the rule of 2. 2% of the population, 2 years old ang presentation, 2 times more common in females. Again, palaging nalilito, male ba yan or females. If you Google, if you check other references, actually nag-iiba-iba talaga siya, hence the confusion. Some reference would say male, some would say female. We stick with Nelson's. Nelson's will tell us that it is female. 2 inches long, yung haba ng defect. 2 feet from the ileocecal valve, yung common na location niya. And you have 2 types of ectopic tissue. Again, it does not apply to everyone. All right. Other miscellaneous gastroenterology facts that you should know. Abdominal pain radiating to the back. Most common cause is trauma, followed by viral infection. This is pancreatitis. Okay? For pancreatitis, ano ba talaga yung mas maganda? So, ang mnemonics ko dito, L is for love. Okay? So, lipase ang sagot. Lipase is more specific, rises faster, and it remains elevated longer. Okay? The only downside with lipase is that it is more expensive and it's not as readily available as amylase. Okay? The most valuable serologic marker for hepatitis B infection, specifically the acute infection, is your anti-HBC antigen. Bakit? Because your anti-HBC antigen, it's the only marker that is positive during the window stage. Okay, so I'm sure you will discuss this more detail in your biochem. Biochem ba? Not sure if biochem or micro. Baka micro. All right? All right. Let's now go to nephrology. Okay. So very important, hematuria, the cutoff is 5 RBC per high power filled for centrifuge urine specimen. Kapag uncentrifuge, that's 10. Okay, so 5 or 10. Pag centrifuge, 5. Pag uncentrifuge, 10. Okay. Sources of hematuria, T-colored, mataas ang protein, dysmorphic. That is glomerular, sa taas. Okay. Gross hematuria, mababa ang protein, normal morphology, sa babayan, lower urinary tract. Okay. Hematuria, hypertension, oliguria, azotemia. HOHA, this is glomerulonephritis. Proteinuria, mababa albumin, mataas lipids, tapos nagmamanas. Think of nephrotic syndrome. Okay. Post-streptococcal GN is the most common, one of the most common causes of glomerulonephritis in children. Please remember these important facts. It's caused by your pyogenes. Other name for pyogenes is your GABs, your group A beta hemolytic strep. It is not your Agalactiae. Okay, it's not your Agalactiae. It's not your GBS, group B strep. Hindi yun. It's strep pyogenes. Okay, it can come from either the throat or the skin. Pwedeng parehas. If it's from the throat, you document the infection by an increasing ASO titer. If it's from the skin, the better test would be your anti-dsDNA. C3 level is decreased. Also decrease in SLE and MPGN. So very important fact. Pag alam mo na usually ang renal disease, tatlo lang ang bababa ang C3, PSGN, SLE, saka MPGN. Pag alam mo na ganun siya, di pag binigyan ka sa exam ng mababang C3, tatlo na lang agad yung differential diagnosis mo. Okay? Pag full-blown glomerulonephritis, then probably APSGN yan. Ang SLE at MPGN, usually ang presentation niyan mix, nephritic, nephrotic, or more on nephrotic siya. Okay? Sabi natin mababa yung C3 ng PSGN, it should normalize in 8 weeks. Otherwise, if hindi pa siya nag-normalize, then probably hindi yan PSGN. Okay. Protein excretion and hypertension coincides with your acute phase 4 to 6 weeks. Okay. Because your acute phase is around 6 to 8 weeks. But please remember that your hematuria can last long. So microscopic hematuria can be present for around 1 to 2 years. All right. On the other side of the spectrum, you have your nephrotic syndrome. Okay. On your dipstick, it should be 3+ pataas. Okay. +1, +2, baka pwede pa. UPCR is more than 2. If you do not have UPCR, 24-hour protein correction, more than 3.5 grams in a day or more than 40 milligram per body surface area per hour in children. The most common cause is minimal change disease. Your minimal change disease will respond to steroids 95% of the time. If it does not respond to steroids, you do your biopsy. Okay? And the most common cause of nephrotic syndrome that does not respond to steroids, when you do your biopsy, probably you will see FSGS. So please put that in your heart. Dapat sobrang kabisado niyo yan. Probably matatanong sa exam yan. All right. UTI is also a very common question. Okay, manifest with only fever, pero it can manifest with anything and everything under the sun. That is your pyelonephritis. No fever, no renal injury, cystitis yan. The most common organism are your colonic bacteria, such as your E. coli. So pinaka-common overall sa UTI sa bata is E. coli, followed by Proteus and Klebsiella. Okay. The gold standard for diagnosis of UTI is your urine culture. The drug of choice is your second-generation cephalosporin, such as your cefuroxime, or you can also give amoxicillin clavulanic acid. Ampicillin has a high resistance. Cotrimoxazole, medyo mataas na rin yung resistance. Okay? Ampicillin, amoxicillin, medyo mataas yan. All right. Microangiopathic anemia, thrombocytopenia, renal failure. This is your RAT, R-A-T. That is your hemolytic uremic syndrome. Hemolytic uremic syndrome, pero may neurologic manifestation, may fever, mas common sa adults. This is your TTP. Acute loss of kidney function leading to a rapid decline of GFR. This is your AKI. Pag AKI mo nag-persist more than 3 months, that is your CKD, your chronic kidney disease. Okay? Let's now go to hematology and oncology. So, anemia with increased reticulocyte, that is your expected response. Okay? Dapat pag may anemia yung pasyente, ideally tataas yung reticulocyte niya. Kapag hindi tumaas or bumaba pa, think of bone marrow pathology. Okay? If normocytic, probably it's bone marrow damage or decreased stimulation. If microcytic, your differential diagnosis is your CLITS. If macrocytic, it's folic versus B12. So, dapat naka-compartment na yan sa utak niyo. Pag may anemia kayo, tignan nyo, tumataas ba yung reticulocyte? Pag tumaas yung reticulocyte, then probably hindi sa bone marrow yung problem nyo. Probably sa labas ng bone marrow. Okay? Pero pag yung reticulocyte bumaba or hindi tumaas, yan. Ang next na titignan mo is yung pathology. Yung characteristic ng RBCs mo. Kung normocytic ba siya, microcytic ba siya, or macrocytic. Alright. Microcytic anemia, sinabi na natin yung CLITS, very important mnemonics. Macrocytic, sinabi ko na rin kanina, B12 versus folic acid. The most common cause of anemia in infancy and childhood, it's nutritional, it's IDA. Okay? The total iron binding capacity in IDA is elevated versus in chronic disease, it is low. So, if you want to differentiate chronic disease versus IDA, one of the parameters that you can look for is your TIBC, your total iron binding capacity. The RDW in IDA is elevated versus in thalassemia, it's normal. So, lagi kong sinasabi yan. So, if you're not given electrophoresis results, if you're not given ferritin, TIBC, transferrin levels, kapag CBC lang, saka RBC morphology lang yung binigay sa inyo, look for the RDW because it will help you differentiate thalassemia from IDA. Again, IDA, elevated RDW, red cell distribution with, thalassemia, normal. Okay, Doc, absolute ba yan? Palagi bang ganyan? No. This is just a guide. Of course, if you want to diagnose IDA, you do the better tests, which is ferritin, iron levels, so forth and so on. If you want to diagnose thalassemia, you do your electrophoresis. Okay, management of IDA is iron therapy. For thalassemia, you give your folic acid, but ideally, the management, in reality, the management is really actually transfusion kung kailangan and splenectomy kapag pag severe yung thalassemia, pag lagi ka ng transfuse. Okay? Remember, alpha thalassemia, you have 4 different presentation depending on how many foci focus is involved. Pag isa lang yung tinamaan, that is silent. Pag dalawa, that's your thalassemia trait. Pag tatlo, that's your hemoglobin H disease. And pag apat, that's your hydrops fetalis. Pag beta thalassemia, dalawa lang yan. Major saka minor. Okay? Other forms of hemoglobinopathies, abnormality in spectrin, abnormal shape of your RBC. Spectrin is the skeletal protein. If this is abnormal, you have a loss in the biconcave shape. Kapag nawala yung biconcave shape niyan, sinisira siya ng spleen, this is your spherocytosis. Okay? Osmotic fragility test is the diagnostic test of choice. But if you do not have that, you can also look at the MCHC. Okay? All right. Presence of your HBS. Your HBS is susceptible to polymerization, resulting in reduced flexibility. This is your sickle cell disease. All right. Wilms versus neuroblastoma. Nadaanan ko na rin to sa aking discussion. This is also very important. Relatively magkaparehas yung kanilang age group. Okay. They present with abdominal mass. The origin of Wilms is renal, neuroblastoma, kung saan-saan pwedeng tumutubo yan. Midline, favorite question. Wilms, hindi siya tumatawid. Neuroblastoma, it crosses the midline. Associated symptoms, Wilms, konti lang. Si neuroblastoma, sobrang dami, iba-iba. Metastasis, lungs si Wilms, si neuroblastoma, bones. Okay? Diagnosis is similar, but remember for neuroblastoma, you have to do your VMA and HVA. Okay? Treatment, almost similar yan. Okay. Leukemia. So, you have to know leukemia dahil siya yung pinaka-common na cause ng malignancy in children. Okay? So most common cause is leukemias. Most common leukemia is your ALL. Sa peripheral blood smear ng ALL, you see pancytopenia and hypercellularity versus aplastic anemia. Sa aplastic anemia, meron kang pancytopenia pero hypocellular sila. And then you have signs of infiltration for ALL. Sa aplastic anemia, sa AA, wala kang signs of infiltration. In bone marrow, you see blasts and hypercellularity. Versus in AA, hypo and fatty infiltration. Prognostic factor is treatment, age, and initial leukocyte count. That is the top 3 prognostic factors that we look at for ALL. Okay? So, ito. Nasa handout din lahat, pero please remember this. This has been asked multiple times in the past 3 years. Okay? Site of spread is liver, spleen, and lymph nodes. Dun siya kumakalat. When you say relapse, gumaling na siya pero nag-relapse siya, it's your bone marrow, CNS, and testes. And ito yung favorite na tinatanong nila. What are your poor prognostic factors? Less than 1, more than 10 years old. Okay. Male, WBC of more than 50,000 upon presentation, CNS, and mediastinal mass. Okay. Lymphoma na regional, yung adenopathy, hindi siya kalat-kalat. With a bimodal age group, this is Hodgkin's. Ito, most common lymphoma in children, tapos systemic, kalat-kalat siya. Kaya siya may organomegaly, that's usually your non-Hodgkin's. Okay? Bone tumor, metaphysis, sunburst pattern, spindle cell-producing osteoids, this is your osteosarcoma. Okay? Ito, diaphysis, onion skinning, and they are undifferentiated small round cell, that's your Ewing's sarcoma. The most common solid tumor are your brain tumors followed by your abdominal tumors. So sa bata, brain tumors, abdominal tumors yung susunod. All right. Let's now go to neurology. Okay? These are paroxysmal time-limited changes in motor activity or behavior. So hindi lang puro motor, pwede rin behavior. From abnormal electrical activity in the brain, these are your seizures. Okay? Kapag predisposition to generate seizure, and you diagnose this if you have 2 or more unprovoked dapat, more than 24 hours dapat yung pagitan, this is what you call epilepsy. Okay? Initial activation is limited to one part of the brain. So, pag isang part, focal yan. Pero pag kumakalat siya, that's generalized. Okay? Continuous activity or recurrent without regaining of consciousness, more than 5 minutes. This is the operational definition of your status epilepticus. So, blood workup for patients with seizure, ano yung mga kailangan nyo i-check? These are the electrolytes that can cause derangement. These are the electrolytes that when deranged might cause seizure. It's your glucose, sodium, calcium, magnesium, phosphorus. Okay? You also check for your blood gas because hypoxia will cause acidosis and acidosis might trigger seizure. And you also check for your AED. Ano yung AED, doc? Anti-epileptic drug levels. These are for patients who are on maintenance medications already. So, kapag meron kang patients na naka-maintain ka na tapos nagkaroon ng breakthrough seizure, you have to check their AED levels. Baka mamaya, hindi pala tinatamaan yung optimal levels ng anti-epileptic drugs nila. Okay? Favorite question ito sa board exam and most of the time nagkakaroon ng confusion. Kailan ba talaga maglulumbar puncture? Okay? For patients presenting with febrile seizures, first episode, first time nag-convulsion yung bata, okay, na may lagnat. Si PPS, sabi niya, pag 18 months pababa, pag less than 18 months, sorry, hindi 18 months pababa, pag less than 18 months, so 17 pababa, less than 18 months, automatic, dapat may lumbar tap yan. Okay? So, meaning, basta first febrile seizure sa PPS, kapag less than 18 months, itatap mo yan. Si Nelson, ito yung sabi niya. Pag less than 6 months with fever and seizure, okay, kailangan tatap mo yan. 6 months, sabi ni Nelson. Or, if ill-appearing, tap mo rin yan. Or, any age, pero meron kang signs and symptoms of concern, meron kang Brudzinski, meron kang Kernig's, mukha siyang meningitis talaga, itap mo siya. Sabi niya, for 6 to 12 months, optional siya if deficient siya in these vaccines. So, Hib saka strep pneumo. Okay? And I think, ano pa nga ba isa dito? Nandito na pa rin, nabanggit na yan. So, ito yung criteria ni Nelson's, ito yung kay PPS. Doc, alin ba talaga yung susundin namin? Okay? Guys, ideally, ang sasabihin ko sa inyo, kay Nelson's tayo. Okay? But why am I teaching you this? Why are we teaching you this value? Because this is a very common information and this is a very common practice. So even if outdated to, even if luma na tong guidelines ng PPS na to, halos lahat ng doktor sa Pilipinas alam itong fact na to, okay? And halos lahat sinusunod pa rin to. Although, yeah, halos lahat sinusunod pa rin to in practice. So that is why we are reiterating this para alam nyo. Because if this were asked in the exam, pag tinanong kayo, for example, should all patients with first febrile seizure na less than 18 months, should they undergo lumbar tap? Then I think your answer should be yes, because this is based on the PPS guidelines. Okay, so is that clear? I hope that's clear. Okay, major risk factor for recurrence of febrile seizure, less than 1, kapag less than 24 hours lang yung lagnat, tas nagsi-seizure siya, or pag sobrang taas ng lagnat niya. So, if your patient fall under these category, then malaki yung chance na every time na nagsi-seizure yan, baka mag-convulsion siya. Okay? Right. So, rare before 9 months, okay, dapat may lagnat, generalized, not more than 15 minutes, normal dapat yung PE, occur only once in 24 hours, that is your simple febrile convulsion. Okay? Ito may mga nalilito dito. Doc, ano ba talaga? More than once in, once in 24 hours or once lang siya during the duration of the illness? For example, nag-pneumonia yung patient, tapos 3 days siyang may lagnat. Once lang ba dapat siya nag-seizure? Or paano, Doc, pag nag-seizure siya nung unang araw, tapos nag-seizure siya ulit nung pangatlong araw, pero tigi-isa lang? Okay, doon nalilito. Okay? Again, we go back to Nelson's. Kasi yung ibang reference, guys, ang sasabihin nila, dapat sa isang sakit, sa isang illness, kunwari, 5 araw yung illness mo, dapat once lang. Pero sabi ni Nelson sa libro, sabi niya, once in 24 hours. So, in the exam, ito yung sasagutin natin. Okay, ito yung isasagot natin. So, dapat ma-fulfill nyo lahat. All of the above. All of these facts should be fulfilled for you to label your patient as having simple febrile convulsions. Otherwise, if may hindi na fulfill dyan, kunwari, focal siya, kunwari more than 15 minutes or umuulit-ulit siya, then, okay, dapat hindi na yan simple febrile convulsion, dapat CFC na yan, complex febrile convulsion na siya. Okay? CNS infection in children, your top 3 would be meningitis, your H. influenzae, and your strep pneumo. Okay? Immediate management, if your patient have active seizures, again, ABC pa rin. Maraming nalilito. Ang unang sasagot ng iba, diazepam. No. It's still airway, breathing, and circulation. But if you have to give your anticonvulsant, the drug of choice would be your short-acting benzodiazepines, such as your midazolam or diazepam. In bacterial meningitis, what is your finding? It's pleocytosis, increased number of cells, okay, elevated protein, and decreased sugar. Should blood culture be performed in patients with CNSI? Yes. Okay, because 80 to 90% of the time you can get the organism in your blood as well, because majority of meningitis spreads hematogenously, okay, via the blood. All right. Drug of choice for Neisseria meningitidis, it's Pen-G. Prophylaxis, depending on your age, rifampicin, ceftriaxone, or ciprofloxacin. Complication, okay, is your Waterhouse-Friderichsen syndrome. You see this in your fulminant meningococcemia. It manifests with DIC, vasculitis, and diffuse adrenal hemorrhage. All right. Most severe form of neural tube defects. So you have different forms of neural tube defects. Di ba meron yung meningocele, spina bifida, meron yung spina bifida occulta, okay? The most severe form is your myelomeningocele because all of the layers are involved. Skin, spinal cord, and even the bone. How do you prevent such from happening, yung mga neural tube defects nyo? Okay, you give your folic acid supplementation. Please remember the numbers. I placed it there dahil laging may nalilito sa exam na pagpapalit yung milligram sa microgram, na pagpapalit yung 0.4 sa 4. Okay? For the general population, it's 0.4 milligram or 400 micrograms per day. If you have a history of neural tube defect, the dose is multiplied by 10 times 10. Kaya nagiging 4 or 4,000 micrograms. Seizures, mental retardation, shagreen patch, periungual fibromas, candle dripping appearance on the ventricular cavity. Think of tuberous sclerosis. Chromosome 17, cafe au lait macules, inguinal and axillary freckles, optic glioma. Think of neurofibromatosis. Right. Let's now go to pulmonology. Okay. Your patient has stridor. It's a viral disease. Kapag virus, usually may mga prodrome yan, such as hoarseness. This disease responds to racemic epinephrine. On X-ray, you see your steeple sign. The level of obstruction is subglottic. This is your laryngotracheobronchitis or your viral croup. You should be able to differentiate this automatically with your epiglottitis. Yun yung pinaka-common na pinagtatabi nila sa exam. The most common foreign body in children is nuts, your peanuts. Okay, the top 3 organisms of rhinosinusitis and also acute otitis media, it's your strep pneumo, Moraxella cataralis, and your non-typable H influenzae. Okay, so hindi siya Hib, hindi siya yung type B. It's your non-typable H influenzae. The management for acute rhinosinusitis, if it's bacterial, it's amoxicillin or co-amoxiclav. You can give amoxicillin na high dose, or you can give co-amoxiclav. Ragged tracheal air column caused by Staphylococcus. This is your bacterial tracheitis. Okay. Lower airway disease. So kanina upper airway, ngayon lower airway. Pertussis, whooping cough, di ba? Ito yung mga paroxysmal coughing, tapos nagbabark siya, tapos tuloy-tuloy, tapos mag-e-end siya sa expiratory whoop. Okay, the drug of choice is your macrolide, your azithromycin. Okay? Wheezing na less than 2 years old, may fever, and other household members have the same illness. May ubo-sipon lagnat, tapos nagwi-wheezing siya. Think of bronchiolitis. So again, hindi lahat na nagwi-wheeze ay asthma, hindi lahat na asthma nagwi-wheeze. I had a patient last week, ang manifestation niya was vomiting. Okay? Vomiting and cough, walang wheezing on auscultation, pero lo and behold, normal yung x-ray. I managed the case as asthma. I gave bronchodilators, steroids, nag-respond yung patient. So this patient was presenting with vomiting, post-tussive vomiting. Turns out, on history, mukhang asthma pala siya. Okay? For the management of asthma, the drug of choice is inhaled corticosteroids. For exacerbation, it's SABA, your short-acting beta agonist, plus steroids. Okay? Pneumonia with consolidation, what etiologic organism would you think of? Strep pneumo. Pag may air leak and pneumatocyl, think of staph. So notorious si staph na nagkakaroon ng pneumatocyls. Pag pumutok yung pneumatocyls, pneumothorax, air leak. Okay? Right middle lobe syndrome, very common, infiltrates in the right lobe. Chronic cough, weight loss, lymphadenopathies, okay, with exposure to TB, then think of tuberculosis. All right. Most common cause of pneumonia across all age group. So pag ang tanong sa inyo, all age group, regardless kung bacteria, virus, fungal, anong pinaka-common, it's viruses pa rin. Okay? Mas common pa rin ang virus compared sa ibang etiologies. Okay? Pero pag bacterial cause ang tanong, your answer should be strep pneumo across all age group. Okay? Most common cause of ORT is rhinovirus. Most common cause of viral pneumonia, it's your RSV. Okay, huwag pinagpapalit yun. Sa taas, rhinovirus. Sa baba, respiratory syncytial virus. The drug of choice for pneumonia A, or your low-risk pneumonia, or your mild pneumonia, it's amoxicillin. For PCAP-C, this is your moderate risk pneumonia. This is your ampicillin, if not fully vaccinated against Hib, but if the patient is fully vaccinated, you can still actually give your penicillin G. Okay? When do you consider shifting your antibiotic if you do not have any improvement in 2 to 3 days? Okay. Pathogens considered in patients with pneumonia above 5 years old. Think of your atypical microorganisms. Think of Mycoplasma, Legionella, Chlamydophila. Okay. Okay. Tuberculosis, very important. Our cutoff is actually 10 millimeters, but 5 millimeters is the cutoff if you have the following risk factors. So immunocompromised with exposure, with X-ray findings, and if you have signs and symptoms. Lagi rin tinatanong sa exam, ano ba yung GON complex na yan? Ito yung composition niya. It's your primary focus with regional adenopathy, peritracheal adenopathy, and localized pleurisy. Right? How many parameters before you diagnose your patient as having PTB disease? Kasi meron kang TB exposure, infection sa disease. Bago mo masabing disease yan, dapat ma-diagnose mo siya, dapat maka-fulfill ka ng 3 out of the 5 parameters. Okay? Again, please review the regimens that we use. Dati meron niyang category 1, 1A. Ngayon, ganito na lang, mas simple na. Regimen 1, okay, is for your TB except those CNS and bones and joints. So for most cases, ito yung ginagamit natin. 2-HRZE, quadruple therapy, and then 4-HR for a total of 6 months. Kapag central nervous system or bones and joints yan, mas matagal, 12 months yung total. 2-HRZE lang dapat yan, hindi yan double R, and then 10-HR. Okay? Yan, meron na nga akong 30 minutes left. Sige. So, whether new or retreatment yan, as long as expert is sensitive or indeterminate, we use this regimen. Okay, so again, this is from the DOH 2020 National TB Control Program. So, this is available for download online. Pero probably ito lang yung kailangan nyo. I don't think babasahin nyo yung buong manual na yun. So, screenshot nyo na lang to. Okay? Let's go now to rheumatology. Okay. Kawasaki disease, how many days of fever nagrepresent ang Kawasaki disease? It's usually at least 5 days of fever. How many criteria should be fulfilled? Dapat 4 out of the 5. So sinabi ko sa inyo, namumula from head to toe, conjunctivitis, rash, any type, basta dapat walang vesicles. Okay. Adenopathy, usually unilateral, usually more than 1.5 centimeters. Redness of the tongue and oral mucosa, and hand and skin changes. Okay, the complication that we look out for is your coronary artery aneurysm. Happens most commonly at the subacute phase. The treatment is IVIG plus aspirin given at an high dose, your anti-inflammatory dose. And afterwards, pag okay na yung pasyente, pag lampas na siya dun sa acute phase at subacute phase, binababa na natin yung aspirin to your antiplatelet dose, which is lower dose. Okay? When is 2D echo done on diagnosis? You repeat after 2 to 3 weeks. If normal parehas, you repeat after 6 to 8 weeks. Pag may findings, mas frequent na yung monitoring. Okay? Sabi natin, pag nagbigay ng IVIG, dapat maging afebrile na yung patient. Kapag may fever pa rin siya, after 36 hours, ang tawag dyan, IVIG-resistant Kawasaki disease. Okay? Alright. Gotron papules, heliotrope rash, okay, focal areas of myositis. Tapos, meron kang neck or abdominal muscle weakness, Gower sign, airway disorder. This is your juvenile dermatomyositis. Palpable purpura, abdominal pain, joint pain. It's the most common cause of non-thrombocytopenic purpura. It's IgA-mediated vasculitis of the small vessels. Kung ang Kawasaki is medium-sized arteries, ito small. This is your Hinoch-Schönlein purpura. Take note that the management is supportive. Hindi lahat binibigyan ng steroids. We only give steroids for severe cases of HSP. Okay. Less than 16 years old dapat. Okay. Tapos dapat more than or equal to 6 weeks. So, chronic disease siya. And the onset is defined depending on how many types of joints are involved during the first 6 months. This is your JRA or your JIA, juvenile idiopathic arthritis. 4 or less joints affected, it's oligoarticular. 5 or more, it's polyarticular. Kapag may rash and may fever, it's systemic onset. Okay? Autoantibody disease resulting in inflammation of your different organ system. Think of SLE. So sa SLE, halos lahat pwedeng tamaan. Skin, joint, blood vessels, CNS, okay? The most sensitive test for SLE is your ANA, pero pag specific ang hanap natin, anti-dsDNA or anti-SMIT. Ang anti-SMIT, sa SLE lang siya nagpa-positive. Alright, let's go to cardiology. Okay? Closure of ductus arteriosus, 10 to 15 hours. Anatomic closure is 2 to 3 weeks. So this is physiologic, this is anatomic. So again, how do I remember this? 14, di ba? 14 hours physiologic closure, 14 days anatomic closure. The most common cause of acyanotic congenital heart disease, think of VSD. Kapag cyanotic, okay, think of TOF. TOF, when does it present? Is it immediately after birth or usually mga first year of life? Ang TOF, first year of life, okay? Kapag early onset, cyanosis on birth, think of transposition, TGA, okay? Systolic ejection murmur, okay, right-sided enlargement versus regurgitant, tapos left-sided. Yung regurgitant nyo na left-sided, this is VSD. Yung ejection nyo, tapos right yung lumalaki, that is ASD. Okay? Machinery-like, bounding pulse, this is a dead giveaway. Dapat alam mo agad yan, pag machinery-like, PDA yung sagot. Okay. Tetralogy, because it's one of the most common, because it's the most common cyanotic heart disease. Dapat alam niyo lahat to. Components is proved. The mnemonics is proved. Pulmonary stenosis, RVH, overriding aorta, and VSD. The most important lesion is your pulmonary stenosis. Because depending on your stenosis, dyan nagde-depend yung kanyang degree of cyanosis. Stet spell. The trigger is your catecholamine release and decrease in systemic vascular resistance. How do you manage it? Very popular is your knee-chest positioning. You also give your vasoconstrictors, morphine to calm the patient. Kasi usually ito yung mga patient na umiiyak, nagwawala. Oxygen, bicarbonate, and your beta blockers. Okay? Early onset cyanosis, increase pulmonary blood flow, egg-shaped cardiac silhouette. This is your TGA. Okay. Weak, okay, delayed or absent femoral pulses. Mas mataas yung BP sa kamay kaysa sa paa. Okay. Rib notching. This is your coarctation of the aorta. I've only seen 2 or 3 cases of coarctation. The typical location of coarctation is in the descending aorta, distal to the origin of your left subclavian vein. Another favorite board exam question yan. Okay. Please remember your rheumatic heart disease. Diagnostic criteria, it should be 2 major or 1 major plus 2 minor. Kailangan ma-fulfill mo yung required evidence of strep infection. Okay. Major factors or major criteria is your Jones. Minor is your Frappe. So joints, carditis, nodules. Remember that Sydenham-Chorea is a standalone criteria. Kapag positive ka nito, then probably that's already rheumatic fever. Okay? Also, remember that when you use arthralgia as a minor factor, hindi pwedeng sabay. Meron kang major na arthritis, tapos meron ka pang arthralgia. Hindi na pwede yon. Pag nag-major ka na dito, hindi mo na pwedeng gamitin yung arthralgia. Okay? Alright. In rheumatic heart disease, please remember it's migratory, it's polyarthritis, and usually affects the large joints, and it responds to salicylates. Pag nagbigay ka ng aspirin, nawawala yung sakit niya. Classic auscultatory findings, not present, but you have signs of valvular dysfunction seen in 2D echo. This is subclinical carditis. Before kasi, bago ka mag-diagnose ng carditis, dapat meron kang auscultatory findings. Pero they've seen that a lot of patients with rheumatic heart disease, normal on auscultation, pero on 2D echo, meron kang mga findings. And that is what you call subclinical carditis. Erythema marginatum, laging tinatanong yan. How do you describe this? It is non-pruritic, serpiginous, erythematous, okay? Never on the face, it disappears when cold, reappears when warm. Standalone criteria, nabanggit na natin yan. For recurrent rheumatic fever, pwede ka ng 3 minor. So sabi kanina, dapat 2 major, 1 major plus 2 minor. Pero for recurrent, pwede ng 3 minor. Ibig sabihin, nag-RF ka before, tapos hindi ka nagbigay ng prophylaxis, hindi ka nagpatusok ng PNG, nag-rheumatic fever ka ulit, 3 minor lang ang na-fulfill mo, pasok na yon, RF na ulit yun. Okay? So management is to give your penicillin, okay, to eradicate your group A strep infection, anti-inflammatory agents for 6 to 8 weeks, aspirin or prednisone, and the prophylaxis is PenG every 21 days. Doc, pwede bang 28 days? For areas with high risk for rheumatic fever, which includes the Philippines, nandun tayo sa high risk areas, tayo yung mataas yung incidence, ang recommendation is 21 days. Okay, so in other areas, they can use the 28-day interval. All right, so the difference between innocent and pathologic murmurs, hindi na natin masyadong ifo-focus to. Dr. DK, ilang minutes pang time ko? 15. Okay, infectious disease. All right. So, neonatal conjunctivitis, think of Neisseria gonorrhea, chlamydia trachomatis, or in rare instances, pwede kang magkaroon ng Pseudomonas. Pero mas common itong dalawang nauna. Okay? In older children, it's usually adenovirus and staphylococcus. Yan yung mas common. For skin infection, most of the time, think of the two. It's either your strep pyogenes or your staph. Okay? Skin infection from insect bite, pero nag-progress siya, nagkaroon siya ng blistering, fever, tapos usually distributed in the peri-orificial area, paligid ng bunganga, paligid ng puwet, saka umbilicus. Think of your staphylococcal scalded skin syndrome or your Ritter's disease. Okay, the drug of choice is oxacillin for methicillin sensitive, Clinda or Vanco for MRSA. All right. Viral exanthems favorite sa board exam to, guys. 3 C's, cough, coryza, conjunctivitis, cephalocaudal, think of measles. Shorter duration than measles, tapos meron kang kulani sa likod ng tenga, think of rubella. Measles is otherwise known as rubeola. Rubella is also known as your German measles. Huwag pagpapalitin. Rash after the fever. Kapag yung rashes lumabas, pag nawala na yung fever, wala ka nang ibang iisipin kundi roseola. Different stages present at the same time. Meron kang tuyo na lesion, may bago ka na vesicles pa lang, kalalabas pa lang. Think of varicella. Slap cheek appearance spares the palms and the soles. Think of your erythema infectiosum. Dengue fever is also a common question in the exam. It presents with leukopenia, pababang WBC, thrombocytopenia, and hemoconcentration. So very important yung hemoconcentration. Here are the warning signs, okay, that is commonly asked in the exam: abdominal pain, vomiting, fluid accumulation, liver enlargement, okay. Pathophysiology of dengue is increased capillary permeability. Because of your virus, because of the inflammatory response, nagkakaroon ka ng increased permeability. Pag yung capillaries mo naging mas permeable, nagkakaroon ka ng leakage, this causes all of these problems. Okay? Test for the first 3 days, please remember, it's dengue NS1. 5 days onwards, that's when you do your dengue IgM, IgG, or dengue blood. And the management for dengue is actually supportive. Okay? HIV, tinanong din ito 2 years ago. Mandami nilang tinanong sa HIV, that's why we place it here. Vertical transmission, either intrauterine, intrapartum, during delivery, or postpartum. Your breastfeeding can be a cause of HIV transmission. Timing of your diagnostic test for infants born to your HIV positive mothers, okay? You do your viral diagnostic testing in the first 2 days of life, and then 1 to 2 months, and then 4 to 6 months. So 3 beses tayo nagte-test, okay? And your CD4 and CD8 counts at 1 and 3 months old, and it's repeated every 3 months starting at the 6 months of age, okay? For your viral assays, ito yung mga yan. Ano ba yung mga HIV viral detection test? Ito yung mga yan, okay? All right. Parasitic infection, pinworm, the drug of choice is pyrantel pamuate. Wuchereria and Brugia, it's your diethyl carbamazine. Echinococcus granulosus, it's albendazole. For your flatworms, it's praziquantel. For trematodes, it's praziquantel. And for ascaris, it's albendazole. In the Philippines, guys, ito yung very important. Starting 12 months of age, we do our deworming every 6 months. We use either mebendazole or albendazole. Okay. Sexual development. So, eto, tinatanong din to guys, ano yung arrangement? You have to know the difference between girls and boys. Sa girls, mauuna ang telarch, followed by pubarch, and then growth spur bago papasok si menarche. Okay? So, mas mauunang nag-growth spur ang mga babae. Sa lalaki, nauuna ang gonadarch, pubarch, adrenarche, saka pa lang yung growth spurt. Okay? Definition, precocious puberty is secondary sexual changes before the age of 8. Sa babae, sa lalaki, 9. So, magkaiba. Delayed puberty is pag wala pa siyang secondary sexual changes, tapos 13 years old pataas na sa girls, sa babae, 14. Okay, so please remember those numbers. Okay? So, sa Nelson's, guys, kuminsan iba-iba kasi yung number, kaya ako nilalagay dito. So, gaya dito, sabi dito, ang telarch 10 to 11. Pero in the adolescent chapter 8 to 12. So, Doc, anong isasagot namin? Siguro ito, kasi ito yung mas common na information. Okay? So, if parehas na merong 10 to 11, saka 8 to 12, I would choose 10 to 11. Okay? Bakit ko sinasabi nangyari yan nung isang board exam few years ago? Alright? So, menses usually come 2 to 2.5 years after the telarch. Okay? Yan. Right. Sige. Most common cause of hyperthyroidism in children, this is your Graves' disease. It's autoimmune. You look for your TSH receptor stimulating antibodies. Other features of Graves' disease, you have your ophthalmopathy and your pretibial myxedema. Okay? What is your thyroid panel findings in Graves? Mataas yung thyroid hormones mo, your T4, T3. Mababa yung thyroid stimulating hormones mo. And positive ka, of course, of your TRS antibodies. Definitive management is radioactive iodine ablation or thyroidectomy. Pharmacologic management, you can give your PTU or metimazole. PTU is preferred in pregnant patients. In endocrinology for PEDIA, ang must know guys is Graves' disease and your Hashimoto's thyroiditis. Okay? Kapag may goiter yan at hyperthyroid yan, probably that is Graves' disease. Pag yun yung nasa exam nyo. Kapag meron siyang goiter pero euthyroid siya, most of the time it's euthyroid and asymptomatic. Wala siyang symptoms, wala siyang signs and symptoms of hyperthyroidism, tapos wala rin yung myxedema, wala rin yung ophthalmopathy, think of Hashimoto's thyroiditis. Sa Graves, ang hinahanap natin TRS antibodies. Sa Hashimoto's, ang hinahanap natin yung TPO antibodies, your thyroid antiperoxidase. Okay? And I think that is my last slide. Okay? Wait lang. Meron pala akong hindi na ipakita. Last topic na hindi ko na-discuss. Hindi ko alam kung bakit siya naka-hide. Oh, nawala. Hindi, yun na pala yun. Sorry. So, that's it. So, meron bang questions? I hope everything is clear.
Hi, Doc Ian. Thank you po for that very yield. Wow, maaga natapos si Doc Ian. 'Di ba? Dahil binigyan siya ng time limit. Okay? The Doc, anong tawag dito? May nag-message po sa akin na student asking, clarify yung effect daw ng knee to chest position during TET spells in TOF. Alam mo to. Increase in SVR or decrease in SVR? Thank you, Doc.
Sige. Should we discuss this now? Medyo mahaba yung discussion yan eh. Sige. Yung knee to chest position, I will discuss that in details. May naka-allocate dyan sa, sa pearls nyo. Pero basically, pag nag-knee chest position siya, yung SVR guys, tingnan nyo muna kung ano yung SVR na tinutukoy niya. Is it your systemic vascular resistance or your systemic venous return? Pag nag-knee chest position ka, yung systemic venous return, meaning the blood going back to the right side of the heart, okay? Pag nag-knee chest ka, ang effect nun, bababa siya. Isipin mo, naiipit yung mga vessels mo, yung mga big vessels mo. So, Pag naipit siya, yung blood going back to the heart, to the right side of the heart, bababa siya. Tapos yung SVR na systemic vascular resistance, meaning yung blood flow palabas dun sa aorta, okay, yung systemic vascular resistance niya, technically tataas siya. So, kailangan mo kasing ibaba yung systemic venous return at kailangan mong itaas yung systemic vascular resistance para maputol yung TET spell. Okay? So, does it make sense? Malinaw ba?
Okay, Doc. It makes sense naman. Sana clear. Sana
Wait lang. Pag
question.
may time ba tayo? Pwede
Kung
ako magpakita ng slide on that kasi. May time pa ba tayo?
sige, Doc. No problem. Yes, Doc. Umaga kayong natapos. You still have 10 minutes actually.
Sige. Wait
Pero
lang.
can I read the other question?
Sige. Sige, sige. Ano yung other question? Doc, napuputol.
Dosages ng different
Sorry,
vitamins.
sorry.
Choppy?
Sorry. Nag-choppy.
Yeah, you can hear me now, Doc. Clear ba?
Wait lang. Yan,
Choppy
sige.
pa rin? Ayan.
Medyo choppy pa rin eh.
Choppy pa rin? Naku.
Sige, ano yan? Okay, go.
Yan, enough ko na yung video ko, Doc. Yan, can you hear me?
Yeah.
Ayan, Doc. So, ang tanong nila, if there is a summary or table of dosages daw po ng different vitamins and minerals like iron or vitamin D and rickets, is there such a thing sa handout natin or what's your comment on it? Is it needed ba? Yan, Doc.
I don't think it's needed. Wala pang nagtanong ng dosage sa buong 12 years or more ko na nagtuturo. And actually, even for residents and fellows, usually magkakodigo pa nga kami dyan eh. So I don't think it's needed, except siguro yung mga pinaka common like vitamin K, which is 1 milligram, parang ganun. Pero for the rest, probably not. Wag niyong sayangin yung time sa pag-memorize ng dose. Never pa may nagtanong ng dose for the board exam, for the board exam.
Okay, thank you, Doc. One more question po. Same lang po ba daw ang anti-dsDNA and anti-deoxyribonuclease B for pyoderma in rheumatic fever?
Same lang siya. Yeah.
Okay, Doc. Thank you.
Anti-DNase B, anti-deoxyribonuclease B. Ano yung tanong? Tama ba? Ano yung sabi niya? Same lang ba yung... Sorry, parang nalito ako.
Kung same lang ba daw yung anti-dsDNA at saka yung anti-deoxyribonuclease B. Pareho lang ba daw yun?
Hindi, iba yan. Anti-dsDNA is for SLE.
SLE yun, di ba?
Yeah. Anti-dsDNA is for SLE. Ang for pyoderma is anti-deoxyribonuclease B.
Right. Thank you, Doc. Thank you po.
Mali ba yung na-show ko sa slide ko? Baka mali yung na-show ko dun sa slide.
Ayan, na-correct nyo na if mali man yung nalagay nyo, Doc. So, ayan, I hope clear yung nagtanong about the dsDNA and anti-DNA.
Yeah, mali nga yung nasa slide ko, sorry. So, it's anti-deoxyribonuclease B.
Okay, thank you, Doc. Ayan, maraming salamat, Doc Ian, sa inyong very high yield na what you call this refresher lecture. Ayan. So I'm sure maraming natutunan yung ating...
Pakita ko muna yung kung may time pa tayo discuss ko na
yes,
yung
Doc.
textile.
Yes, Doc. We still have time.
Sige. Para habang nakikinig sila. Baka hindi nila mapakinggan mabuti ito sa Pearls eh. Ayan. Kita niyo yung slide?
Kita, Doc, kita.
Yeah. Guys, ganito yung nangyayari sa TED spell. So, sa TED spell kasi, meron kang obstruction dito sa outflow tract. This is the right side of the heart. Right atrium, right ventricle. Okay? So, meron kang obstruction dito. This is your pulmonary stenosis. Okay? So, what happens in your TED spell, either pag nag-spasm yung RVOT mo, so, sumisikip yan, okay? Or nag-increase yung iyong systemic venous return, bumadami yung blood papunta dito. So, tignan nyo dalawa, kaya ang daming nalilito kaya ayokong ginagamit yung SVR So, systemic venous return, it's the blood going back to the heart. Okay? Systemic vascular resistance, it's the resistance of the blood going out of the aorta. So, yan yung vascular resistance mo. Ano ba nagtitrigger sa TED? Ang TED spell natitrigger siya kapag sumisikip yung outflow ng pulmonary stenosis mo, okay? Kapag yung blood going out of, ito pala yung aorta. Kapag yung blood going out of the aorta mo, bumabagsak yung resistance, systemic vascular resistance, saka kapag maraming masyadong blood na bumabalik sa heart mo. Bakit? Pag sobrang dami ng blood na bumabalik sa heart, okay? Tumataas yung systemic venous return mo. Pero unoxygenated blood yon, wala siyang mapuntahan papunta sa lungs. Saan siya pupunta? Pupunta siya dito. Magsha-shunting ka. Pupunta siya sa aorta. So, mataas na nga yung systemic venous return mo. Okay? Mataas na nga yung systemic venous return mo. Tapos, mababa pa yung vascular resistance mo. So, lahat ng blood na unoxygenated, palabas siya, mapupunta siya sa systemic circulation kasi mababa yung systemic vascular resistance mo, di ba? And that will cause decrease in oxygen, hypoxia, hypercarbia, acidosis. Okay? Pag meron kang hypercarbia at acidosis, bibilis yung respiration, so lalo pang tataas yung venous return. So, ito yung common na management ng TED spells na nakikita nyo sa libro. Okay? So, yung Nietzsche's positioning, saan tayo dyan? Ayan. Sabi dyan, it increases your systemic vascular resistance. So, tama yan. Okay? So, pag nag-Nietzsche's positioning ka, tumataas yung systemic vascular resistance mo. So, imagine niyo tumataas yung resistance ng blood going out of the aorta. And why do we like that? We like that para yung unoxygenated blood, hindi siya free flow papunta sa systemic circulation para mas marami siyang time na lumusot dun sa maliit na butas na yon papunta sa lungs para ma-oxygenate siya. So yun yung purpose ng increasing the systemic vascular resistance. And one way to achieve that is yung Nietzsche's positioning. Ngayon, ano bang nangyayari naman sa venous return pag nagni-Nietzsche's ka? Sabi dito, it increases the volume. Actually, pag nagte-TED spell, gusto mo rin ng volume, kaya ka nagbibigay ng fluids para mas marami kang preload para ma-improve mo yung circulation ng heart. The problem is, yun nga, walang saysay kung marami kang preload pero hindi mo naman siya mapapunta sa lungs. Tapos, pumupunta lang yung unoxygenated blood, nagsishift ka lang. So, one way to decrease yung blood return dun sa right side ng heart would be to do your Nietzsche's positioning. Okay? So, ang Nietzsche's positioning, sabi dito guys, it increases systemic venous return. Pero actually, if you will look at the studies, para yan yung, isipin nyo may host kayo. Pag pinindot nyo yung host, di ba? Inipit nyo ganun, initially, maraming tubig yung sa opposite end niya, pabalik dun sa heart, marami yung pupunta. So initially, yes, mag-i-increase ka ng venous return. Pero pag matagal ka nang naka-Nietzsche's, naipit na yung host mo, ano yung magiging end effect niya? Siyempre, naiipit nga yung blood vessel So, ang magiging end effect niyan, mas kukunti yung blood going back to the right side of the heart. And do we like that? In a way, yes. Para nga, mabawasan yung shunting. Para kumbaga, dahan-dahan yung blood flow papunta sa right side, mas makakapunta siya dun sa lungs. At the same time, hindi rin makashunt mabuti kasi tumaas yung ating systemic vascular resistance. Again, ang gusto natin to eliminate the TED spell is again, to try and give your blood more time to go through that narrow canal para mapapunta siya sa lungs para ma-oxygenate siya. Okay? So, yun yung quick rundown nung nangyayari sa TET spell. So, Doc, sa exam, ano bang isasagot namin? So, sa exam, pag tinanong kayo ano bang ginagawa ng niches, ang isasagot nyo is it increases systemic vascular resistance. No question on that. Okay? Pero ano ba talagang ginagawa niya sa systemic venous return? So, it increases it initially, pero after that, it decreases the venous return na. Doc, paano pag nasa choices parehas? Increase or decrease ba ng venous return? Ang isasagot nyo guys ay increase. Okay? Bakit? Again, mas common na knowledge kasi yan. Okay? Yung sinite ko sa inyo na studies, yung sinite ko sa inyo na explanation na end effect, journal level knowledge siya. So, for the board exam, mas maganda na we stick to this. Increases vascular resistance, increases venous return. Okay?
Okay, Doc. Thank you. Thank you again. Ayan, ng questions. Okay, Doc, salamat po. Oo. I will introduce na lang our next speaker. Okay, wait lang guys. Ayan, so for our quiz master for tonight, we have Dr. Tricia Marie Ramos Galapon, a graduate of the University of the Philippines, Manila, and took the board exam, very fresh pa, October 2022, and she placed top 7 in the recently concluded board exam. So, ayan, she will give us the quiz master for tonight. Dr. Galapon, are you here? Good evening. Good evening, Doc.
Good evening po, ma'am.
Okay, Doc. You can share your screen na, Doc.
Okay po. For a while lang po.
Okay, mga BBs, mag-participate kayo, okay? I will launch the poll after Dr. Galapon read the question. And then doon sa mga BBs na nasa portal, sagot din kayo, okay? Sagot din kayo on your own para ma-practice pa rin kayo. Okay? Alright, Doc, game na.
Okay, okay po, Doc.
Okay, thank you, Doc.
Okay, good evening, everyone. Happy New Year. Let's start our Pediatrics with Master session. So for the first question, after a prolonged vaginal delivery, a newborn presents with a prominent swelling on the head. The swelling overlies the parietal sutures with minimal discoloration in the area. Which of the following is true regarding the condition? Okay, so majority answered letter D. So the answer is letter D. So given that case, the diagnosis is Kaposi coccidium. Let's see what differentiates it from cephal hematoma. Here on this slide, we can see the differences, no? The infants can present with molding, especially in prolonged labor or assisted delivery. In Kapot, there's edematous swelling on the scalp which crosses the sutures, as mentioned by Dr. Ian kanina. There may be bruising on the area as well, and it reaches its maximal size at birth, and it resolves within a few hours. On the other hand, cephal hematoma is subperiosteal bleeding that is limited by the sutures. And compared to Kapot, its size progresses from the time of birth, and it resolves in weeks or even months, depending on the size. It is important to differentiate this from another condition mentioned in kanina, which brings me to this next question. What is the collection of blood under the aponeurosis that covers the scalp? So this is subgaleal hemorrhage. As I said, it's important to differentiate this because this is more toxic, and the bleeding can spread to the eyes or even to the knee. Okay, next question. A 6-year-old boy was brought to his pediatrician for easy fatigability. Auscultation of the chest reveals a grade 3 murmur that extends from S1 to S2. The murmur is best heard at the left fifth ICS mid-clavicular line and radiates to the axilla. 2D echo will most likely reveal okay, so majority, around 60% answered letter B. So here are the salient points of this case. So our answer is actually letter A. So for my questions about murmurs, it is important to determine if they are innocent or pathologic. And then you can narrow down the possible causes by taking note of the location, the timing of the murmur in relation to S1 or S2, is it systolic or diastolic, if there are any radiations or any associated clicks or splitting of the heart sound. So as seen on this slide, you can see yung differences na innocent and pathologic murmurs. So since medyo madami ito, you can just focus on the pathologic murmurs. So any murmur that is that is diastolic, transsystolic, like in our case, with systolic or continuous, or with any associated thrill or click, splitting, asymmetric pulses, these are pathologic. And I put here the grading for murmurs, no, kasi any murmur that is more than grade 2 is pathologic. And again, ano yung murmur, grade ng murmur that is associated with thrill, it's grade 4. So this slide shows the auscultatory areas where you can hear the common murmurs. So let's look at the ejection murmurs first. So they are mostly heard at the second ICS, so at the base of the heart. So sa right, usually aortic stenosis yan. And then on the left is pulmonic stenosis. On the left, here, yung mga pansystolic murmurs naman, they are usually regurgitant. You can see here. And they are best heard at the apex if it's mitral, like in our case. And then here's the left sternal border kapag tricuspid or VSD. And then in the same area here, the letter C, if nakarinig kayo na mid to late diastolic murmur, think tricuspid or ASD. And then mitral stenosis naman dito sa apex. Then lastly, sa yellow area here, which is the left sternal border, you can hear the aortic or pulmonic regurgitation. Okay, next question. Can everyone hear me po? Mahina pa po may audio? Hello? Okay.
Medyo mahina.
Okay, Doc. Sorry.
Yes, Doc.
Okay
Okay.
na po, Doc. Lakasan ka na.
Yan, better,
Okay.
better. Yes,
Okay.
Doc.
So
Thank you, Doc.
Okay. Okay, so question number 3. A 6-month-old baby boy was born with cleft palate and diagnosed with tetralogy of Fallot at 3 months of life. He's often admitted in the hospital due to recurrent pneumonia and diarrhea. Further workup reveals low calcium levels. The immunodeficiency is likely secondary to an answer now. Okay, so medyo hati yung sagot ng students, no? So fair majority, 34% answered A. So looking at the case, medyo familiar siya, no? It looks like a very common or lagi natin narinig na syndrome, which is discharge. So our answer here is a low T cell count. So discharge syndrome results from a disruption of the development of the third and fourth pharyngeal pouches. And you can remember the manifestations with the mnemonic catch-22, as you can see here. Therefore, this question, we will focus on the immunodeficiency associated with it. So bakit nga ba? You can see here, merong thymic hypoplasia. In more severe cases, may aplasia. So when you're presented with a child, tingin nyo may immunodeficiency, you can look for these warning signs. If in general, you should probably work up yung mga bata na may recurrent infections, those who do not respond to antibiotics well, or yung mga may failure to thrive, or recurrent fungal infections, ganun. So these are the warning signs. And then you can see here, no, yung mga classifications na ating mga immunodeficiency disorders. So for cellular immunity deficiency or abnormalities, sa mga patients na you can expect to see yung mga prolonged viral infections or opportunistic fungal or mycobacterial infections. Sa yung defects naman yung antibody production, recurrent respiratory tract infections yan with encapsulated bacteria. A good clue here is if yung manifestations appear after 6 months kasi dun na nawawala yung mga maternal antibodies. And then as you can expect, yung combined immunodeficiency, you can expect na mas maaga yung age of onset nila and mas profound yung effect. Okay. So we have a very quick question here. We have a child with recurrent infections, eczema, and history of prolonged bleeding from circumcision site. The diagnosis is Wiskott-Aldrich syndrome. The next, what is the most common primary immunodeficiency disorder? It is selective IgA deficiency. Okay, question number 4. A 4-year-old male whose diet is restricted to mostly corn and rice presents to the clinic for recurrent diarrhea. He is extremely thin with moon fascies and a pot belly. His nails are thin and soft, and his hair has alternating light and dark bands. The following are true of his condition, except okay, so medyo hati din yung mga answers. But given these salient points in red, the patient probably has kwashiorkor. So our answer is letter A. So na-discuss naman ito ni Doc Ian kanina. So when you look at the presentation of kwashiorkor, it looks more toxic. No? So you can see edema, hair changes, skin changes, poor yung appetite nila, and the moon fascies, tas yung liver nila may fatty infiltration. So marasmus, it seems less toxic, pero sobrang payat nila dahil nga sa severe caloric deficiency. So it is important, no, that when you try to treat these patients, may steps to follow. So that is to prevent the repeating syndrome. So our question here is, what electrolyte imbalances are associated with repeating syndrome? It's hypokalemia, hypomagnesemia, and hypophosphatemia. Ang sabi ni Doc Ian kanina, yung hallmark is hypophosphatemia. So yun yung sinabi ko, you have to stabilize them first and treat any acute conditions before trying to build them up. Okay, next question. Which of the following is not an indication for PPD prior to BCG vaccination? Okay, so 41% answered letter B. Our answer here is actually, yes, letter B. We recall that our BCG vaccine is a live vaccine given intradermally and it's given at birth or preferably within the first 2 months of life. The dose is 0.05 ml for children for less than 12 months and 0.1 ml for those 12 months or more. According to the child immunization schedule, PPD testing is recommended if any of the following is present. First is congenital TB, if the child has a history of close contact with a suspected or known infectious case, or clinical findings suggestive of TB, and or chest X-ray suggestive of TB. So for healthy infants and children greater than 2 months who are not given BCG at birth, PPD prior to vaccination is not necessary. Okay? So ito yung tatlo na recommended na mag-PPD testing muna. Okay? So another question here, BCG is no longer recommended if the induration is how many milliliters? 5 milliliters. Okay, next question. A 2-year-old girl was brought in for consult due to rashes. 5 days prior to consult, the child had fever, Tmax of 37.9, loss of appetite, followed by rashes on the face and neck. On PE, the child is a febrile with generalized maculopapular rashes, enlarged lymph nodes behind the ears, and petechiae on the soft palate. What is the diagnosis? Okay, very good. 62% got the correct answer, which is letter B. Okay, so you have to be very familiar with viral examples. So highlighted here in red are the salient points. Okay, so rubella is a virus, a single-stranded RNA virus with an incubation period of 14 to 21 days and communicability of 7 days before and after the rash. So for the clinical manifestations, usually these patients may prodrome sila of fever, sore throat, red eyes, and other non-specific symptoms. And then they have lymphadenopathies as well. And then for the rashes, they are usually macular, and they appear first on the face and neck, and then they spread cephalocaudally to the trunk and extremities. Of course, it's called 3-day measles kasi usually ganun lang siya kaiksi yung duration ng rash, and they heal without discomminution. So this photo shows lang the patterns of rashes of the common viral exanthems. So the third one here is yung rubella. And then the first one is yung measles, and usually associated siya with the disease, as you can recall. Then here, yung 50 Vs, you can appreciate here the slap cheek appearance. And then here, yung ating roseola or the 60 Vs, usually lumalabas yung rashes niyan after the disappearance of the fever. This slide shows lang the common spots of viral exanthems. So first one, we have the Forchheimer spots. So yun yung mga rose-colored petechiae on the soft palate. And then in the middle, yung measles, yung Koptic spots ng measles, which are white spots sa may baka mucosa near the second to third lower molar. And then the Nakayama spots here, which picture reddish papules on the soft palate. Na nakikita sa roseola. Okay. So we have question here. What is the most serious complication of postnatal rubella? It is encephalitis. What is the single most common finding in congenital rubella syndrome? It's nerve deafness. And then what is the most common ocular abnormality in CRS? It's salt and pepper retinopathy. Okay. The next question, on the house and walks up and down the stairs one step at a time. She can eat by herself using a spoon, and when asked to sit down, then clap her hands, she was able to follow. These skills are consistent with what developmental age? Okay, so majority answer letter B. So, okay, that is the correct answer. So, now this is a question about developmental milestones. No? So, I know it's very difficult to memorize, but for this quiz master session, kahit we focus on the milestones above over 1 year of age na lang. So, kahit for this, yung 2 years old na master, no, that's a very big deal already. So, yun sa case natin, you have a 2-year-old. You can expect them to run well, walk up and down the stairs one step at a time, and they can use a spoon for feeding. They are toilet trained by day and can follow 2 to 3 step commands, and they engage in parallel play. During this time, their vocabulary also greatly expands it greatly expands. So may alam na sila mga about 50 to 100 words. Kaya tinatawag siyang language explosion at 2 years old. At 4 years old, syempre, they learn how to walk muna. And then they run stiffly at 18 months before they can run well. Tapos, pag sa stairs, of course, they crawl muna. And then, someone guides them with one hand held. Then, they walk up the stairs one step at a time bago sila gumamit ng alternating feet like us at 3 years old. So same year then, at 3 years old, they can ride a tricycle. 3 years, tricycle. Okay. During handedness is also established at this time. So before this horse schooling, established na yan. At 4 years, they can hop, throw a ball overhand, and they engage in group play. At this time, visual acuity is 20/20. In terms of drawing, children start by scribbling lines first, but by the 3rd year, they can copy a circle na. At 4 years old, kaya na nila yung cross, and at 5 years, kaya nila na yung square. I'll let you study the rest of the milestones now on your own. Next question. A 12-year-old male was brought to the clinic for tea-colored urine. 2 days prior to consult, the child developed fever and non-productive cough. Vital signs are as follows: HR 95, RR 20, temperature 36.8, and BP of 130/90. Your analysis confirms the presence of RBCs. Which of the following statements about the diagnosis and management is true? Okay, so medyo hati yung majority answer letter A, pero medyo hati sila with letter C. Answer for this question is actually letter D. where we have a child here with hematuria and elevated BP, which are characteristics of glomerulonephritis. By this time, you should be able to differentiate between nephritic and nephrotic syndromes. Remember the mnemonic HOHA, and PALE for their characteristics. So the case we're dealing with is likely IgA nephropathy, since the onset of renal symptoms is 1 to 2 days after an infection. Compare that with PSGN, where the symptoms appear 1 to 3 weeks after a streptococcal infection. Kapag PSGN, we request ASO titers or anti-DNA to confirm strep infection. When you compare the C3 levels, low yung sa PSGN and normal naman siya sa IgA nephropathy. For the management of IgA nephropathy, the mainstay is BP control and management of proteinuria with either ACE inhibitors or angiotensin receptor blockers. If these are ineffective, corticosteroids are recommended. And then for PSGN, supportive treatment then with sodium and fluid restriction, diuretics, and calcium channel blockers. And penicillin G for 10 days can limit the spread of organisms. Actually, dati kapag mga exams, nagkakamali din ako dito dahil sa onset. Pero usually, kapag PSGN, mas matagal yung onset ng renal symptoms. And remember na yung C3 natin ay low. Second to the last question, we have here a question on pulmonology. What is the preferred initial therapy for a 10-year-old asthmatic child with symptoms less than 2 times a month and no risk factors for exacerbation, according to the recent GINA guidelines? Okay, so majority answered letter A, as needed SABA, followed by low-dose ICS whenever SABA is taken. The answer is letter B. Okay, so this is a figure taken from the recent GINA guidelines for starting asthma treatment in children 6 to 11 years old. In the interest of time, we'll be focusing na lang on the treatment for step 1, for yung mga patients na may symptoms less than 2 times a month, and step 2, yung more than 2 times a month. Okay, so as you can see here, the preferred controller is first step, the preferred reliever I mean here is SABA or low-dose ICS for Formoterol as maintenance and reliever therapy. Remember though that the child has to take low-dose ICS whenever SABA is taken. And then if for the step 2, daily low-dose inhaled corticosteroids. Yeah, remember ito yung for 6 to 11 years. So step 1 and step 2. Contrast that with treatment for adolescents greater 12 years or more ang age. For step 1 and step 2, para silang as needed low-dose ICS for Formoterol. Just remember guys na it is not recommended to give SABA alone na ha. Okay. And then for the last question, a medical intern was tasked to examine a 6-week-old baby in the wards. When the moral reflex was elicited, there was no response. Which of the following can best explain this? Okay, majority, 42% answered letter B, followed by letter A. The answer is CNS dysfunction. For the boards, you have the most important thing to remember here is the age of disappearance of the primitive reflexes. I highlighted here yung motor reflex. It appears before birth and persists until the 5th to 6th month postnatally. Most of them develop before birth, apart from the parachute reflex, which developed in slightly older infants. Just remember that the absence or presence of these reflexes during a specific time can suggest a neurologic abnormality. To elicit the motor reflex, the infant should be supported in a semi-erect position, then allowed to fall backward onto the examiner's hand like in this photo. A normal response is symmetric extension and abduction of the fingers and upper extremities, followed by flexion of the upper extremities and an audible cry. Kapag asymmetric naman, I noticed na maraming sumagot nito, na fractured clavicle, brachial plexus injury or hemiparesis. Asymmetric moro yung presentation nun. Kapag absent, parang mas iisipin mo during that time, 6 weeks old pa lang siya, dapat meron siyang moro. Think of a significant CNS dysfunction. Lastly, this is my last question now for tonight. What primitive reflex is a prerequisite to walking? So it is parachute reflex. So this persists throughout life as seen in the slide earlier. Okay, that's it for our Quizmaster session. Thank you guys and Happy New Year.
Wow, thank you very much, Doc Trisha Galapon, for that wonderful Quizmaster session. Ayan, napakahinhin ni Doc, no? Nahiya tuloy ako. Mahinhin. Charat. Ayun, salamat, Doc. I think our students don't have questions at this point, but we appreciate your time and your effort for making those questions. No, parang feeling ko ang pedia, nagtutell sila ng stories, no? Pag nagtatanong, ang hahaba ng mga tanong. Kasi feeling storytelling for kids ba? But it's really actually PJ is known for that. So at least now you get to have that feel answering those kinds of questions. So thank you very much, Doc Trisha. Good evening po and Happy New Year. Okay? Doc Broly is here with us tonight. Doc Broly, magandang gabi and Happy New Year po.
Magandang gabi, Dr. DK. Magandang gabi, Dr. Trisha. Thank you for giving us a very nice Quizmaster session. So let me give an info for micro. Marami tayong pag-uusapan regarding micro, guys. Stay lang. Tama ba yung naka-show? Share again. Tama yung naka-screen share?
Yes, Doc. Okay po.
Okay.
Correct po.
Okay. For Michael, okay? So, feedback of students for Michael, for the past 2 years, since the revamp ng early 2020, Michael is now one of the easiest subjects in the med boards. This is, when I say easy, this is in comparison with the other subjects. So, together with legal med, probably your grades will be highest for Michael and for med juries. To be honest, even if you don't read the top-notch handout, the top-notch lecture videos, you can actually survive with any material for Michael. Pwede USMLE First Aid lang o kaya Michael MRS lang. You read those, you'll be able to survive Michael. You read your handouts for Michael during med school, you'll also be able to survive Michael. However, okay, we're going to make Michael much more fun for you here in top-notch. We've revamped the Michael handout and Michael lecture videos for March 2023. Together with Pharma, ito yung mga changes na gusto ko talagang mangyari. So ano, Doc, ginawa niyo for Michael? So in comparison with the top-notch October 2022 batch, we've reshuffled the topics to reflect yung textbook flow. So ang breakdown niyan is Michael generalities, then bacteria, okay, and then the other organisms. We've incorporated what we call super tables in parasitology and mycology topics. We have revamped the bacteriology and virology parts to emphasize the important and must-know information. We have retained, kasi maganda talaga yung ginawa ni Dr. Tiffany Uy a few years back, yung mga QR code summaries niya, resulting in a much shorter handout from the 95 pages noong October 2022, it's now down to just 71 pages. We've also made changes in the faculty lineup. The one that will give your main lecture videos will now be Dr. John Borbe and Dr. Franz Rubio. Dr. John Borbe will also be the one to give your Pearls lecture for Michael. So, instructions. For all previously enrolled students, ignore the past Michael handout. Utilize the new Michael handout, revamp. Also, watch the new micro lecture videos. Enjoy the subject. Masaya tong subject na to. Okay? Magaling na lecturer si Jan at si Franz. Maganda yung ginawa nilang handout ngayon. Okay? There's a handout na kumakalat yung ginagamit namin dati, yung natawag na micro super tables. Please do not use the micro super tables anymore. Everything na importante dun sa micro super table, nandyan na sa bagong micro main handout. So gamitin nyo lang yung micro main handout na yan, 70 plus pages with a very good lecturers. Yan na lang please. So pre-test, main handout plus main lecture videos plus post-test, that will still be the strategy. Okay? So use this time. Probably you'll be able to finish the lecture video and the lecture handout in 2 to 3 days. You don't need all the 5 days for micro. So I would recommend that you use the extra time that you will possibly have in this subject to address your backlogs. Now, in terms of backlogs, my personal recommendations for that, you have 3 options that I can recommend. How to handle backlogs. Option 1 is gawin nyo araw-araw, Monday to Saturday. You allot just 1 to 2 hours for that. Usually, either at the start of the day or bago kayo matulog. Highly recommended yung 9 p.m. to 11 p.m. yung bago kayo matulog, 2 hours before you sleep. That's the time that you catch up on your backlogs. Option 2, instead of doing it daily, you arrange it in weekly blocks. For example, every Saturday and Sunday, you do it for 4 hours, 7 p.m. to 11 p.m. The other option, option 3, is that you schedule your backlogs only after all the 12 main lectures are done. So ang goal nyo na lang is hindi na madagdagan pa yung handout, ay hindi na madagdagan pa yung backlog. Mag-focus kayo para tapusin lahat ng mga pasunod na subjects. Tapos yung backlogs, schedule nyo siya during the mastery period natin from late January to early February. Okay? Among these 3 options, Doc, what will you do kung kayo kumukuha ng board exams kasabay namin? Probably, if I were in your position, I'll probably do option 2, yung weekly blocks. Yung 4 hours lang every Saturday and every Sunday. Okay? Bakit? This is to give me, probably if I'm in your position, para to give focus and attention, concentration doon sa current subjects. Kasi every time magbabasa ka pa ng ibang subject, ng backlogs daily, parang nawawala ka sa nawawala ka sa synchrony with the current subject. Okay? So probably if I were in your position, I'll do yung Saturday and Sunday. However, this will again vary depending on your personality, your study strategy, okay? Just be aware, okay? To prevent further backlogs, kailangan mo talaga ng disiplina Gino-goal setting mo dapat yung sarili mo na, halimbawa, after 2 hours, dapat eto na yung natapos ko na module. Or after 3 hours, dapat natapos ko na halimbawa itong respiratory system. Okay? And then dapat may malaki kang alarm clock sa tabi mo. At yun yung gagamitin mo, gagamitin mo yung alarm clock pag halfway ka na, halimbawa, 2 hours ang naka-allot for that particular module. Mag-set ka ng alarm after 1 hour. Para ngayon, meron kang trigger na dapat tapos ka na halfway after 1 hour. So you do that, you really have to live according to an alarm clock. Please do not use your cell phones as alarm clocks. You get yung very big alarm clocks. Yung may bell talaga, yung maingay talaga. Okay? Never study na nakahiga. Never study sa kama. And try to use a large screen as possible to watch the lecture video. Wag cellphone, wag iPad. Masyadong maliit. Utilize TVs, utilize large monitors. Utilize kahit bumili kayo yung tigwa 1,500 pesos na projector. Tapos i-project nyo na sa wall ninyo. Okay? That will give you a very large video output. Okay, yung large screen na yan, guys, iba yung impact pag malaki talaga yung screen versus maliit yung screen. Iba. So utilize that for the remaining subjects. The mentoring program has already started. They will orient you further regarding self-regulation skills, time management, how to process your feelings, all of this. So if you don't have a mentor yet, we highly recommend that you get one. Okay? Your teachers for this subject. For the main lecture and main handout, your main teacher is Dr. John Borbe, top 1 ng March 2019 board exams. Okay? A graduate of UST, not UPCM. He's a graduate of UST, top 1 ng boards, took his internship and IM residency in UPPGH. Graduated just this year. Okay? Your other lecturer for parasitology, entomology, and mycology is Dr. Franz Rubio. Top 5 ng class nila, consistent quiz bee champion. Your teacher also for biochem. He's taking up IM residency right now in St. Luke's. Graduate of UP Med. Okay? And then you also have for the lecturette, yung mga QR codes. Narin yung QR codes, guys. Maganda yung QR codes ni Tiff. Dr. Tiffany Grace Uypul. Okay? So top 5 ng 2020 PLE valedictorian of UP Med 2020. Almost got perfect grades during pre-med and current IM resident in St. Luke's QC. You have a powerhouse teachers. So main lecturers will be Borbe and Franz Rubio. Pearl's lecturers will be Borbe. Okay? So enjoy Micro, the top-notch guys. Thank you so much. Let's hear a testimonial regarding the previous board exams, kung ano yung mga galawan, mga tanungan, at ano yung recommendations specific for this subject. DK?
Yes, Doc Broly, thank you very much po for that introduction to microbiology and for teaching also the students kung ano yung technique. So share ko lang, Doc Broly, nung time ko, yung backlogs talaga ginagawa ko 1 or 2 days after ko matapos yung mga main handouts. It's effective for me. Depende yon sa style nyo. So anyway, ayan, ang ating intro to microbiology will be given by Dr. Caitlin Edeluina Yap Legaspi, a graduate of the University of the Philippines College of Medicine and took the board exam last October 2022. We'll be sharing with you some tips on how you will study this subject. Good evening, Dr. Legaspi.
Hi, good evening po.
Yes,
Good evening,
Doc.
Kate.
Oh, do I share my slides?
Sige,
Or...
share your slides na, Doc.
Okay, all right.
So konting background lang si Dr. Kate is a graduate of UP Med. His dad is a teacher of mine sa UP Med. Kaya sobrang thankful ako nandito. Parang parang cycle, no? Yung teacher ko, tinuruan ako, and now I'm teaching. Tinuruan ko yung mga anak nila. So natutuwa lang ako that she volunteered to be part of our mentorship program. Okay, so Kate, back to you.
Okay, so hi everybody. I took the PLE last October 2022. So in general, micro is a fair exam and it is, as Broly said, fun. Dr. Broly said, fun to study. So it's a fair exam pero wag siyang pabayaan, right? Like you might hear again and again that it's easy, but it's easy compared to everything else. but because everything else is so hard, that makes this exam feel fair. So the topics are spread very well between microbiology, parasitology, and virology. So you really do have to go through everything. And I want to reassure you in that everything you're going to need is in the handout, the videos, and the flashcards already. So there are some recurring topics based on previous samplexes. However, my batch noticed that this current board of medicine really likes curveballs. So you might have noticed in previous tests sa PLEs, meron mga international organisms na wala naman sa Pilipinas, like there would be questions about Lyme disease, rickettsia, and stuff. And I looked for it sa boards namin, pero wala. So our boards naman, I noticed that there were a lot of organisms that were really local, like yung names ng organisms may Philippinesis, may Ilocana, may Ilonggo, words like that. It became very local. So diagnosing the organism involved was very fair. Like when you read the case, it would be very classic yung presentation. Like alam mo na yun yung classic presentation. So really know the organism and the classic presentation associated with it, because ayokong mangyari sa inyo na nakita mo and you said, oh, this is the classic presentation, but I forgot what organism. So connect the two always in your mind. You would have a lot of two-step questions in the sense that the organisms may not be named outright, but you'll be given a case, and then you'll be asked, you'll be given a case with a classic presentation, you'll be asked what to do for that organism, but the organism will not be named, things like that. So in this kind of thing, people who did medtech will have an advantage. We noticed lots of questions relating to the other subjects, which makes sense. They would ask how you would test for an organism, what are the management guidelines. For example, we had lots of questions about TB, like the guideline stuff. How would you swab it? What kind of sample would you take? How would you manage it? Like what antibiotic regimen, things like that. So study microbiology not just for the microbiology test, but also because it's very useful and it will come up a lot in PrevMed, IM, Pedia, Patho, and Surgery. Your teachers are really, really good. Si Dr. Jan, nagturo siya sa amin ng Pearls last October, and I love the lecture so much kasi parang bumalik ako sa hospital, and I could really see the patient in my mind when he talks about it. And Dr. Friends is also really good. Like nagturo siya sa amin sa mga reviews for students before nung I was still in med school, and he public health siya ng undergrad, so this is really his jam. Okay, next slide. Oops. Okay, so how do you prepare for this? Like all the other subjects, you prepare in general. You want to have a broad overview of everything. Para worst comes to worst, if you can't say what's the right answer exactly, you have an instinct for what the right answer is. You can't really predict what kind of curveballs they'll throw at you. And this board of medicine really likes curveballs, but there are some themes that recur. So for general knowledge, broad overview, and also it will help with the curveballs. Para at least, you have an overview of everything. For the recurring organisms, one of the hardest things for boards in general is memorizing. So keep that knowledge fresh in your mind by refreshing it with the flashcards. The micro flashcards of Top Notch are very good. You can do practice questions, and because the samplexes are curated na for you, you'll notice that recurring topics in the sample exams will probably also be organisms that come out. Not the same questions, but the same train of thought, the same important things associated to those organisms. So one way to make this easier for yourself, one way to make sure to tie in the knowledge to the other disciplines also and help you remember it, is when you're studying the clinical diseases, yung IM and Pedia, they each have an infectious chapter, right? After you've studied micro, when you're reviewing for that, don't allow yourself to pass by an organism where you can't name something about it. Okay, so naaral mo na yung micro, bumalik ka ng IM and Pedia, kung may nakita kang organism, wag mong pabaya na name, dapat you should know something about it. Don't just let it pass by. PrevMed, the organisms testing guidelines will be very helpful for you, as well as yung local management guidelines for it. And then pharma. Personally, pharma has always been my Waterloo. So the way I made it easier was that when I was sinabay ko yung pag-aaral ng micro with yung antibiotics, yung pharmacology. Like, if I saw in the pharma handout, I would treat this organism, I had to know what that organism was. Conversely, if I was reading micro and I said, oh, I have to treat with this antibiotic, at the very least, I had to name what the drug class was and maybe some notable things about the drug, if I can still remember. So when you're reviewing for these other subjects, it's nice to have your micropara handout open for easy reference. So later, if let's try to avoid backlogs, but if it happens, if you feel like you studied it well, just keep refreshing your knowledge with the practice tests and flashcards, even while studying other subjects. If you get to the point where you can't cover all of the material, know what kind of learner you are. If you have to prioritize the videos or the handouts, what you think will go down easier for you. The best thing for me really was to tie it in with the other subjects, because that made it real for me, because new organisms, you can't really see it, but when you see it, what it looked like in the patient, that's what makes it very real. So pag crunch time na, pag crunch time na, like Pearl season, do your tests, read the feedback, and understand why the correct answers are the correct answers and the wrong answers are the wrong answers. That way, and I think really the best advantage top-notch gives you is the fact that you have tests with feedback. When you do practice tests kasi and you answer it by yourself, if no one tells you what the right answer is, there's sometimes you're not really sure. So when top-notch explains it to you na this is why it's correct and this is why it's wrong, you're not just answering the question. You're also remembering important things about the choices which might come up in other questions. So good luck. I want to reassure you again that you got everything you have. Just study well.
Thank you, Doc Kate, for that introduction. So ayan guys, punong-puno na kayo ng mga bala how you can study this subject well. And I hope we helped you, matulungan namin kayo na aralin mabuti ang micro and to ace the exam. So yon, thank you very much for joining us tonight and happy New Year everyone. Thank you, happy aral. Ay, Doc Broly, sorry, may announcement pa po ba kayo? No, we're not.
None. Okay? So just take the mentoring. Kung mga hindi pa nagpapa-mentor, highly recommended. Okay? So thank you, Dr. DK. Thank you, Kate. Okay, for very nice info lecture. Okay, for Michael and our previous teacher, si Dr. Galapon. And Ian. Si Ian ba yung kanina? Si Ian
Yes,
De Vera.
Yes,
Okay, for the Pedia Refresher lecture. Thank you so much, everyone. See you soon. Okay? We'll have some on-site classes mga patikim near the so pinag-uusapan na namin ngayon. We'll finalize it end of January. We'll make the announcement early February. Do not reserve airline tickets, dorms without us giving you instructions kung kailan at kung saan siya gagawin. Okay? Yun yung ipa-finalize namin ngayon January. Thank you so much everyone. Bye.
Thank you.